All. Good evening, all. At the outset, I would like to welcome you all on this Sunday evening, behalf of Indian Academy of Otolaryngology and Head and Neck Surgery. This weekend, we have planned a webinar series on difficult scenarios during Stapes surgery. And we will be having a lecture on stepidotomy, risks and long-term benefit by our keynote speaker, Dr. Joachim Muller, senior otologist with many years of experience, who is the head of the cochlear implant and hearing prosthetic section, Department of Otolaryngology, Head and Neck Surgery, University of Munich, Germany. And this entire session is going to be moderated by our ever hero otologist, Manoj from Messier, Calicut. So without wasting time, I would like to hand over to Dr. Manoj to take over this today's evening session.
Yeah, thank you so much, Vijay. And once again, thank you so much for allowing me to moderate this session. We have among us a great panel of faculty. Professor Joachim Muller, everybody would be aware of. He is the head of the prosthetic division and ENT Otology Center at Munich. He is a very senior professor with a lot of years of experience. His work on cochlear implants, brainstem implants, mid-ear implants, and other otology conditions are far too many to even enumerate here. I welcome you, Professor, to this conference, and I'm sure that people here would be benefited from hearing from you. At the end of Professor's talk, we'll be having a series of 4 other lectures by myself, by Dr. Neelam, by Professor Mohan Kameshan and Amit Kishore. And from then on, we'll be taking the discussion. So without much ado, Professor, we can start your talk.
So, hello, good evening to India. Welcome to all friends in India on the screen. It's my pleasure and honor as well to present in this esteemed panel to describe some techniques for stapedectomy and giving some results, long-term results and short-term results, and prepare the introduction lecture for this panel. I'll try to share my screen so that we can continue with the presentation. And I do hope that will work out. So, can you see the screen?
Yeah, we can see it, brother. It's all clear. The slides are good.
Very
I can
good.
hear you well.
Yeah. Then we'll discuss some basics, some surgical considerations for stapes or stapedectomy or stapedotomy, discuss the risks, describe some intraoperative findings, and at least discuss the results. So Stapes surgery comes from ancient Greeks, and that means translated something like handicraft, which describes the procedure pretty nice. The stapes itself was first described by Ingracius, 1546. 1672, it was clear that the sound conduction mechanism through the middle ear goes through the ossicles to the oval window. And since 1760, it is known that the cochlea is filled with fluid, which was an experiment from Meckel in Halle in Germany, who in winter times was about to do some preparations in a temporal bone, and he left it outside overnight, and it was freezing. So the temporal bone was broken. And by that, Meckel found out that inside the cochlea, when the bone was broken, was fluid inside. And since that, it is known that the cochlea is filled with fluid. When it comes to otosclerosis, we find normal tympanic membrane, progressive hearing loss, conductive or combined, and the otosclerotic foci are mainly located at the posterior cruise according to Schuknecht's investigations. If it comes to physiology, the vibrations in the ossicular chain for sound conduction are usually inward-outward for the stapes footplate, moving like a piston, whereas if you have a PORP or a TORP, this leads to some tilting movements or making the stapes not longer rocking like a solid body, but bending a little bit through. But this is not the topic of this talk. For stapes surgery, the intact ossicular chain works like a piston inward-outward, and this explains why the surgery is so successful when replacing the fixed stapes through a prosthesis. Surgical procedures go back to Kessel, 1876, with stapes mobilization. Then fenestration procedures came into the discussion of the promontory or from the horizontal semicircular canal, especially Lempert's surgery is well known in the literature throughout the world. He moved to New York later on, and Lempert's surgery and Lempert's procedure made him a rich man while doing that. 56, stapedectomy was introduced by Shi and modified by Schuknecht, Plester, and others. Latest modification came as called stapedotomy, not to remove the complete stapes, but creating a hole inside the stapes footplate to carry the piston. Surgeries and risks surgery is indicated when the conductive component is large enough, and therefore the tuning fork test Rinne appears negative, and then surgery is indicated. We do the surgery if no upper respiratory tract infections are present, and we counsel about all the risks about hearing loss, damage of the facial nerve, taste, vertigo, and wound healing disturbances, and general surgical risks. And in Germany, according to the legal situation, we have also to counsel about alternative procedures, especially hearing aid as an alternative, and we may maybe have a hearing aid trial prior to surgery. Well, before it comes to surgery, everybody has his procedures, and we do it like George, have an espresso before doing the stapes surgery, and then we'll go to the table and find the pure pleasure inside. Our technique is endoral incision in front of the cartilage. Alternatively, it can be done transcanal through a fixed speculum, which is also widely spread, but I have no experience with that. We were used to do it under local anesthesia. Nowadays, general anesthesia is done for 95% of the patients, maybe according to their comfort or to the influence of anesthesiologists who suggest this procedure to the patient. However, both procedures have advantages and disadvantages. We cannot control the immediate hearing improvement under general anesthesia. However, if we create vertigo under a local anesthesia procedure, this is also not comfortable, neither for the patient, not for the surgeon, and this is avoided under general anesthesia. So both has pros and cons, and in our hands, more than 95% of the procedures are done under general anesthesia now. We use microsurgical instruments, perforator, microhooks. We have done and used microdrill, skeeter. Laser has been introduced, but I have no experience with laser in creating a hole into the footplate. However, there are concerns about creating a high frequency hearing loss due to the laser pulse touching the fixed footplate and creating high frequency hearing loss. The procedure is cutting the stapedial tendon, open the incudostapedial joint, fracture the stapes crura, and remove the stapes superstructure. We fracture with the hook in various lengths. The posterior cruise is fractured first, and then the anterior cruise, often fractured spontaneously. Sometimes it needs to be fractured, like here. And then the superstructure is removed. This procedure gives you a little bit more space while introducing the perforation into the footplate, which we do manually with a perforator, and then according to plaster, we remove the posterior third of the footplate, which ends up with a partial platinectomy. After removal of the footplate, a prosthesis is introduced, and this is a wide range for discussions. There are many different prostheses described, from the coarse piston with fluoroplastic, Armstrong style bucket prosthesis, or piston prosthesis from different materials. Our favorite is titanium piston, which is the second one from the right side in the center picture. Smart pistons that close by heating are sometimes dangerous, especially the smart piston, which you see on the picture here, and also the picture and the description in the website describes you why it is a problem. The loop closes completely, but does not pay attention to the variations of the incus. And while it always closes completely, this may lead to erosions of the long process of the incus, which you find under revision. So there's no individual fixation possible. Well, lessons that I have learned over the years is that all experienced Stapes surgeon I talked to internationally did not modify at least very gently the procedures they have learned from their teachers. And introducing modifications always is a result of careful considerations. And even if there are still controversial issues, variations vary among countries, and that was nicely discussed at the otosclerosis panel at IFOS in Dubai last January. Well, one of the challenges that is remaining is the fixation of the prosthesis. These are some pictures with a platinum wire Teflon prosthesis after years where the bending was not properly, or the steel wire prosthesis that is either too loose or had lead to an erosion of the long process of the incus. And to overcome this problem of crimping for those who are persons who like to crimp, we developed a special forceps that is a little bit bended and has two grooves that fit around the incus and allow for crimping of the Stapes prosthesis. That's our favorite one, a titanium band prosthesis. Another solution is the Niti bond prosthesis, which is also heat activated, but is a very smart construction introduced by Huber in Zurich that closes automatically by applying laser heat of 1 joule within 10 to 20 pulses. And then you can model the prosthesis around by heating up the nitinol components and then model it around the incus without applying any forces. With this procedure, one of the risks throughout crimping for incus dislocation is minimized. This works also nicely under surgery, and this was one of the variations that I, after careful consideration, introduced into my procedure. And within about 10 to 20 pulses, you can adjust the prosthesis around the incus. After having done so, mobility is checked, and once it is sufficient, oval window is sealed, and a sponge that was introduced to protect the facial nerve from laser beam is removed. But in an initial study, our colleague Schrötzelmeier published this. We found this prosthesis working very nicely. We had a good airborne gap closure and an improvement compared to the classic titanium prosthesis as well. Both showed unchanged bone conduction. However, the airborne gap was a little bit smaller with a niti bond, and the learning curve was a little bit steeper with a niti bond than with the titanium prosthesis. Also, if we look at the post-operative standard deviation of the mean, then the standard deviation was smaller for the niti bond prosthesis, which reflects on one side the steeper learning curve. It reflects the quality of the reconstruction, of course, the ability of the surgeons, but also it shows that the reconstruction is very precise with minimal variations. If we go to the literature, the risks and the benefits we have to discuss with the patient is the hearing loss, a decrease of hearing over time, deafness, vertigo balance and balance problems, damage of the facial nerve, taste disturbances, wound healing disturbances, general risks, and specific surgical risks for the procedure, which may result in an unintended incus dislocation, a gusher phenomena due to anatomical variations. Floating foot plate is a phenomena which we more frequently have to deal with in selected cases. And also if we suck out the fluid of the inner ear and the vestibulum, this may cause some post-operative problems that should be discussed in the panel as well. Throughout the surgical procedure, we may see tympanic membrane perforation or anatomical variations like tympanosclerosis, malformations, malleus head fixations, which were not detected prior to surgery. Incus dislocation can be managed by doing a malleovestibulum assembly or Gusa or Gusher in the inter-ear. Another aspect which we also should be aware of, that's damage of the instruments under surgery. Maybe a broken hook appears from time to time if the quality of the instruments is low. Well, if we open up the ear in otosclerosis surgery, we can see malformations like in this case, or in van der Heuvel syndrome, we have the stapes like a column, which presents difficulties, or sometimes space between facial nerve and incus. Long process of the incus is very small, and for these we like to use these new type of M-thumb prosthesis, which has a different loop that allows for better fixation around the incus if there's less space. Stapes crura fracture may present a special problem once the foot plate remains mobile, and you see nicely the posterior crura of the stapes moving through the broken foot plate. and we also may detect as associated or new ossicles, third ossicles, which can be removed and find a stapes, a mobile stapes, and then the intervention is not finished as a stapedectomy, but as a PORP with a special prosthesis placed in between the handle of the malleus, the incus, tympanic membrane, and the head of the stapes. Well, in a paper by Sharaf, we looked especially in Stapes revision and outcome. So give you the results first. In Stapes revision surgeries, 80% of the patient reported an improved hearing. And the findings that we found in this series are described in the next slides. So we've found failed incus reconstruction with hydroxyapatite, which led to a fixed prosthesis, but to movements between the cement and the incus. So there was no solution for the hearing improvement of the patient. Improper fixation of prosthesis is seen very frequently. Incus erosion at varied degrees occur with all types of prosthesis, also with the titanium clip prosthesis, which are said to cause no incus erosion, but the picture left side down shows that they indeed can cause erosion. Retraction of the tympanic membrane with developing of a tensor cholesteatoma, extrusion of the incus and subsequent protrusion of the prosthesis is a finding that we can found. And as I said before, if the incus is missing or has been dislocated, the malleus vestibule assembly while fixing the prosthesis in the middle of the handle of the malleus is an issue and the solution. However, the prosthesis can be bended to the individual anatomical needs. There are malleovestibulopexy prosthesis on the market with a joint in between. This never works in my hand, and from revisions I have seen that the prosthesis is extracted out of the oval niche through the mobile joint through scar tissues. So this connection is nice for the surgery to adjust the prosthesis, but it's not long lasting. Overlooked malleus head fixation is something that we found in a persistent conductive component after Stapes surgery while doing the revision. And this can be drilled away either orally or through a second hole in an antrotomy or mastodectomy. Fistula of the oval window are usually associated with vertigo. They appear under the facial nerve canal or around the prosthesis, and we have seen them also around the prosthesis while the perforation was done with a laser. The carbonated holes in the footplate did not allow for proper sealing of the soft tissues and led to a fistula. There's an interesting situation in this type of prosthesis, which comes from audio technologies. Also, the website is questionable with their information. It's a fully pure platinum prosthesis with 999% of titanium. I do not know how they manufactured that, but this put a question mark behind the trustability for this prosthesis. Also, they describe that the last part of the prosthesis is porous polyethylene, and this is known since the late 50s to be not a good material for in the middle ear. And what we saw under revision surgery in several cases is that we have the prosthesis, and there is a gel-like phase in between the prosthesis and the surrounding tissue, which explains the fistula. And this, for me, shows that the material is not well tolerated from the inner ear and the middle ear as an interface in the oval niche. Dislocated prosthesis as a long time result can be detected in CT scan earlier, and this gives you an idea. Intraoperatively, the prosthesis can be withdrawn inside the vestibule and quite very deep, which makes the extraction challenging. The underlying mechanism is that the scar tissue goes around the neck of the piston prosthesis, and while contracting, the prosthesis is coming under tension and then moving through the long process of the incus. There's the paper by Szymanski published in his series of Stapes and Stapes revision surgeries, and that nicely describes this underlying mechanism that we can confirm from our revision findings. Well, in many situations, we can place just a new prosthesis on the long process of the incus, and pulling at the free end of the prosthesis and closing the loop around the incus for more than 360 degrees is, in my opinion, a safe procedure to conduct a good component. Well, this is a picture of a very interesting case, which I not want to discuss too much in detail, but the audiogram on the bottom on the right side shows you two curves, and this is shown because we could demonstrate tension phenomena of the Stapes prosthesis while asking the patients to perform Valsalva maneuver, and after the maneuver he reported increased hearing, and that's what we could demonstrate even in this audiogram, that after the Valsalva maneuver the sound conduction through the ossiculate chain was better, and this was the reason for revision surgery. This was the result 4 weeks after surgery with the audiogram 80% monosyllabic words without a hearing aid, compared to what he had before, 80% with hearing aid or 10% without hearing aid prior to revision surgery. So this was a nice result. This leads us also to the question of a re-ossified or maybe never opened footplate, which we also see frequently. And the situation becomes even more difficult if you have incus missing and have done maliovestibulopexy. And the prosthesis, again, a steel wire prosthesis, moving through the handle of the malleus, resulting in a situation where you have no ossicles where you can fix a prosthesis again. And the solution in this situation is to explore the oval window niche and put in a VSB or a sound bridge system directly into the oval niche and use this for sound coupling into the inner ear. If we have a deafness after Stapes surgery, which can occur directly after surgery or within months and intervals, the solution is CT scan, MRI, and the cochlear implant very short after deafness. In this case, we found ossification of the basal turn, and after drill out, we were able to place a standard electrode. The Stapes prostheses in these cases are left in place. When it comes to revision, the challenge is the steel wire soft tissue prosthesis that has been used in the early days. And this is an endoscopic picture of a patient who experienced deafness after 30 years of Stapes surgery. And you see the steel wire prosthesis, which is not proper fixed, but also shows the scar tissue in the oval niche. And removing this has a higher risk of creating vertigo and damage to utricle and saccule. So also in these cases, the prosthesis was left in place, but with an endoscope, we could take this picture to just highlight that steel wire soft tissue prostheses are a special challenge if they need to undergo revision surgery. So in the end of the revision surgeries, we found a lot of pathologies. It is a little bit like a surprise egg. When you do Stapes revision surgery, you never know what's inside. Be careful, once you want to go to the US, don't import Kinder surprise eggs. It's illegal, and a penalty of $2,500 can affect you once they found these eggs in customs. You can bring them to Canada, and I do hope you can bring them to India as well. But to the US, I found this strange. It is not allowed to. There's one more situation which should be addressed, and that is Stapes revision surgery immediately or very short time after first intervention. And the most common cause for that is foreign body granuloma, like we see in this case. This is an experienced surgeon who did Stapes surgery. Patient went home. One day after, he experienced vertigo. The revision was done, prosthesis was left in place, and 2 weeks later, he experienced deafness. And when opening up, we found this large foreign body granuloma and removed the prosthesis and closed up the inner ear and received only minimal inner ear recovery. So in the end, in our revisions, in about 50% of the patients, we could use a standard length prosthesis. 1/3 was solved with a customized special bended prosthesis with a double L. And in a few cases, we did malleus vestibule assembly to create sound conduction to the inner ear. In terms of audiological outcome, we had a mean airborne gap for the frequencies 0.5, 1, 2, and 4 kilohertz of 12 dB, whereas in the primary cases we had 8.65 dB, which compares quite okay, having RINA positive in these cases. Compared to the literature, it is in the level of what's with other series published, especially from the course clinic. They have also 11.5 dB mean airborne gap for the frequencies. Compared to the series of my teacher, it's similar. However, Grünwald and Helms published, or it did not include the 4 kilohertz, while we included the 4 kilohertz, and this explains why the group within 10 dB is a little bit smaller. However, it is quite nicely comparable, which is not surprising because it's the similar techniques applied. The interesting finding of Dr. Sharaf's work was that we found hearing improvement and hearing deterioration almost in all patients when tuning fork test was negative. And that means if the airborne gap was bigger than 20 dB. So one of the lessons also learned is Stapes revision surgery for audiological results is done if the conductive component is big enough, and that means more than 20 dB. Well, if we have combined solutions, the active middle ear implant combined with a Stapes surgery is a solution. And if you have a far advanced otosclerosis, a cochlear implant instead of Stapes surgery may also a consideration to avoid negative results from Stapes surgery in borderline conditions. For this situation, I want to mention the apical cochleostomy in ossified cochleas according to Montadon, where you insert the cochlear implant upside down. This may be a technique which also is useful in otosclerotic obliterations of the cochlea. Gusher is well known to all of you, and the situation of the stapes should be checked in this situation, whether you have another hole in the stapes or not. And with that, I would like to thank you for listening.
Thank you so much, Professor. It was a very extensive talk, and we really appreciate your data collection, how much of information that we have. We will go through all these things in our panel discussion, Professor. So meanwhile, I'll be giving a small intro on what we are going to do. For the audience, we are going to have 4 presentations here. One is by me, which I will be giving a short intro, which might overlap with Professor Muller's, which I will be skipping. Dr. Neelam Ved will be talking on imaging before and after surgery, and also about immediate management of complications and how that is influenced by imaging. Professor Mohan Kamesan, with his extremely large experience of otosclerosis cases, will be talking about how to prevent complications, because often preventing is far better than actually getting one. Professor Amit Kishore would be talking about what new has come into Stapes surgery, how it has influenced our results. So meanwhile, I'll be sharing my screen, and is it being? Can you show that?
Yeah, Manoj, we can see it.
Is it?
Yeah, we can see nicely.
Full screen? Is it?
Yes. Yes. Yes.
Okay. Now this is what we are doing, and we already know who the panelists are. This is the way in which it is going. And we'll be having exchange discussion between 7:15 and 8 p.m. See, one of the things that we all know is that has there been a rise and fall in otosclerosis over the last 70 years? Some of the young people out here think that otosclerosis is much more commoner in the past and not so common now. And what does data tell us about that? See, when they studied between 1950 and 2017, there were 614 cases of otosclerosis. And from that period, it rose to a peak of 18.5 per 100,000 in 1970 to 1974. The incidence declined to 6.2, and after that, it has been steady at about 3.2 per 100,000. So it is possible that there were a lot of backlog cases, and this 3.2 is actual incidence that we are seeing in the past. Because till then, nobody knew what to do with otosclerosis. Nowadays, we know. So I think for people like us, really, there has been no fall in the incidence of otosclerosis. Because the age at diagnosis and proportion of bilateral cases also has not changed in the last many years. This we know for sure. Now, why do you think there has been a slight decrease in incidence? See, there's been some studies that said that they have actually found out mRNA of the measles virus inside otosclerotic patients' Stapes foot plate. And because of that, with the virus vaccination, there could be some degree of rapidly declining incidence. But after that, it's been kind of steady. They found that when they did measles vaccine in 1963, there was a 15-fold drop on the number of cases. But I do not know how to actually say that what is happening in India. Even now, we have people who are skipping vaccinations, probably, but there has been no decrease. I've been talking to all the senior people who have been doing surgeries, and they have never found that there's been serious decline in the number of cases in the last few years. They also said that since 2000, the number of cases reporting to the US have been all imports. People have been coming from other countries. Now, we will go through one small little video about what is the critical steps required in Stapes surgery. See, the incision, as Professor Muller described, has to start from from above, anterior to the malleus handle to below. We have to raise the flap without tearing it. You have to see the round window niche. You have to curate the posterior canal wall without damaging the incus. You have to see the facial nerve, the promontory, the pyramidal, the eminence, the posterior crura. The posterior crus is often drilled or laserized. The Stapes piston is then measured. People tend to use measuring pistons, but we generally use the same piston. The anterior crus is also drilled. It is okay to take a vein graft, though I don't do it now. I'll talk about that later. And then the vein graft is placed on the fenestra, which is made in the middle of the foot plate. And by always avoiding heavy suction on the foot plate, that's a vein graft going onto the foot plate. And then the piston is placed. First, it has to go into the fenestra and then onto the incus. This is what a good stepidotomy technique should be. There should be avoidance of medial movement. You heard Professor Muller talk about what happens if it goes into the vestibule. Then the stapes superstructure is removed. This is what we call the reverse stepidotomy. You can do it the other way also. Now, there has been some changes that we've been noticing. There was actually incidence of juvenile autosclerosis. People have actually reported that people are younger and younger children are getting autosclerotic foci. In fact, the youngest child that I've operated was 6 years, and whose sister also we operated 9 years. So there's probably some genetic element there. What are the difficult situations that we can face? So you can have a narrow canal, young age, we already described that. We can have an overhanging facial nerve. We'll be dealing with all this in our panel discussions. Persistent stapedial artery. There could be a thick vascular foot plate. You can have a too thick or a too short or a too thin incus, and of course the stapes gusher, perilimb gusher. Okay. Now there has been a lot of studies about gushers in stapes. They say that this phenomenon can happen because a result of abnormal communication between the perilymphatic and subarachnoid spaces. In some cases, they could be due to internal artery canal and might involve the cochlear aqueduct. Now, because of this, there is no real way to predict which patient will get a gusher. Though these days, Professor Neelam will talk about that. With imaging, we're able to find out the third window phenomena. But in spite of having a normal imaging, you can still have a gusher in stapes surgery. Now, this laser, which we'll be discussing in Professor Amit's talk, has been first described by Rodney Perkins. This is his first paper on how to use lasers. It has actually revolutionized what people do with stapes surgery. Now, I will play a small video on how the laser is being used. Here, we make the similar flap, and then after vaporizing the tendon, we make a fenestra exactly of the same size on the foot plate instead of the burr. You'll have to take away the small bits after those little char and then do the stepidotomy in exactly the same way as was done before. The advantages of a laser being that if you use the laser properly, you can make as precise a fenestra as possible. Dr. Amit will be talking more about that. This is one situation that people can face. We'll be going over this in the next panel discussion. So I'll be skipping over this here. You can see the facial nerve prolapsing and touching the facial nerve crura, stapes crura. You could also have a very thick foot plate that can make surgery difficult. Say here you can see the very thick foot plate that sometimes will need a lot of drilling, and then finally opening it up and then putting in the piston. In fact, for many people, a thick foot plate is often a cause of anxiety, though you don't have to really worry about it because in generally, most of the complications of stepidotomy, like a floating foot plate or incus dislocation, does not usually happen with a very thick foot plate. You can use the skeeter and the laser together. This again will be dealt with in Amit's talk. So with a very thick foot plate, you can actually blue line it and then use a laser. Now, one of the problems that people can face in autosclerosis is persistent stapedial artery. This will be dealt with extensively in Dr. Neelam's talk. You can actually see it by aberrant ICA and an absence of foramen spinosum, which she'll be discussing about that. Now, what about post-operative SN loss? You heard Professor Muller talk. When Harold Schucknet wrote this paper, they said that 19 out of 20 losses that he studied, which happened in 750 stapedotomies, were related to surgical technique. And they said out of the 11, they can be related to excessive drilling and other factors being traumatic mobilization, hemorrhage, and instrumental trauma. So there is this element that we can actually reduce by proper surgical technique. So it is possible that as a surgeon becomes better and better, the incidence of postoperative SN loss may gradually become lesser over time. We will again deal with this as in the panel discussion. What about vertigo? They said that there was this particular study which said that the risk of sensorineural hearing loss are higher in the microdrill group, but risk of tinnitus was higher in the laser group, and there was no footplate fracture in the laser group. So it is possible that using a laser can minimize the incidence of vertigo in post-stapedotomy patients. You heard Professor Muller's talk, and here this is the importance of long-term follow-up. This is a patient, 2005, had a stapedotomy surgery in 1 year and then developed hearing loss. And then we did the stapedotomy the other year. This was in 2005. Hearing improved from 67 to 33 dB. And over a period of time, the hearing remains static. Sorry. So till 2009, the hearing is still 32 dB in the operated year, whereas the poorer year remains bad. So here again, we'll be discussing in this seminar about what we should do if there is a failed stapedotomy with SN loss in 1 year. Should we be operating the other year? This is just one example that I have posted. Now, there has been some studies that say that phonophobia after stapedotomy is present in all cases and they gradually disappear over a year. In fact, Matheson in Oslo had this paper in 1969. He mentioned that every patient should have phonophobia. So then there was also this paper by Vittorio Coletti that said that if you do a tendon preservation and use a 0.7 millimeter diameter and a wire piston, you can reduce the amount of phonophobia and improve the results. We also do tendon preservation in some cases, if it is feasible. So here, you're actually taking the tendon out of the way, laserizing only the crura there, and keeping the tendon intact. And I will skip this video and then keeping the tendon in place, do the stapedotomy, and then insert the processes with the tendon still attached to the remnant ossicular chain. So we have found that in some of these cases, there has been a definite decrease in phonophobia, especially when you have done the second year, when the first year had a regular standard stapedotomy. We will again discuss that when we go through the panel discussion. Now, there are a lot of people who have been doing stapedotomy and stapedectomy, and they said that when this particular paper, they said that either technique provides satisfactory and stable long-term results. However, we people who have actually graduated from stapedectomy to stapedotomy find the second technique to be superior. But in good hands, we know that Professor in the Lempert Hospital, Mohan, what is his name? I suddenly forget.
Subramania.
Oh my God, how could I forget him? A great man. He always did a total stapedotomy and got wonderful results. So it is possible that if you have a good hand, whatever you do, you can still get good results. Therefore, this is just a prelim to what is going to be talked about in the rest of the conference. So for all the young people out there who are going to be starting stapedotomy surgery, you have to carefully audit your results. You need to choose wisely. Every patient will require a specific technique. If it is a persistent stapelar artery, ossified footplate, overhanging facial nerve, or whatever. But the importance, you have already seen in Professor Muller's study, how long-term follow-up is important for us to recognize that our technique can improve over time if we study what is going wrong in our hands. And as always, if you use the right instrument in the right way, you can gradually improve on your results. So thank you for this. And we will now be going over to Professor Neelam. I'll be stopping share. We will be dealing with imaging and autosclerosis, preoperative as well as postoperative. Over to you, Neelam.
Do you have my screen?
Yes, we can see you.
Yeah. Thank you so much, firstly, to IAOHNS for the kind invitation to be a part of this discussion. And thanks, Manoj, for giving me this nice, tough topic. At the outset, I'd like to acknowledge Dr. Sanjay Vaid, who has contributed a lot to this presentation. My topic for today is going to be just focused on how imaging can influence a lot of the decisions that we make as far as autosclerosis and its management is concerned. We are all aware about what autosclerosis is. It's a metabolic bone disease, and it usually presents to us with conductive hearing loss or mixed hearing loss. But in about 10% of patients, it can present with sensory neural hearing loss. When we look at the involvement of this disease in terms of the aortic capsule, we see that it's mainly, or 99% of this, is fenestral autosclerosis, which means it involves the oval window and typically more on the anterior part of the oval window. In about 20%, we have what's called a retrofenestral, which is an involvement of the cochlea, or more likely to be the medial wall of the aortic capsule. And in about a 13%, you will also get a shared involvement of the round window. When we look at the diagnosis, or how we've been diagnosing this condition over the last decades or two, it's mainly been focused on clinical history and audiology. And imaging really, if you ask me, has come into the forefront only, I would say, in the last 5 or 6 years. I, however, really do stress that to diagnose this condition, you need a combination, or you need the 3 pillars. You need a good clinical history, a very good audiology, and definitely supported by imaging. The way imaging is going to help us is, firstly, it's going to confirm the diagnosis. Gone are those days where you would tell the patient that, look, I suspect you have autosclerosis, and thereby we would write it down as an exploratory tympanotomy and not a stepidotomy or oblique stapedectomy on our OT lists. It does help us to stage the disease, giving us an idea of how we are going to be talking to the patient about progression, what are the possible complications that we may face. Surgical planning and anticipated problems during surgery, you get a fair enough picture with imaging. And that, again, as a surgeon, reduces the amount of stress that you will have intraoperatively. To talk to a patient about the prognosis, the outcomes, what is it that can maybe go wrong, again, imaging plays a very, very strong role. And less cannot be, or more cannot be said about the management of complications and how imaging really influences us. The 3 modalities that are available to us here are high-resolution computerized tomography, cone beam CT, and MRI. MRI has a very limited role, and I will just talk about it at the end of this presentation. One of the challenges that we faced whenever you talk about imaging and you talk about this to ENT surgeons and radiologists is that you look at the sensitivity. It varies in studies from 60 to 95%. And what is it that you can have some radiologists not able to pick this up and some able to pick this up is what we need to really focus upon. The important thing here to remember is that when you look at it radiologically, this picks up the autospongiotic phase. If the patient, however, has gone into a progressive disease and has more of an autosclerotic disease, then it kind of merges with the bone. And sometimes that, for maybe a not so experienced radiologist, becomes a challenge. So radiologically, it's much easier to pick up autospongiotic phases, whereas in autosclerotic phases, this becomes a bit of a challenge. And at that time, what the radiologist has to really focus on is in change in contours. And if you look at this contour and you see this convex, this is not normal. This is not the way the oval window and the promontory would look like. So this kind of gives us a sort of a indication that, yes, there is some disease happening here. And there's a good study, which I have quoted down there, which really kind of stresses on this point. The other things that are common, and I excuse the crowdedness for this slide, but what I would urge, all of us to kind of go through this paper. Again, in those cases where you're not really sure, is this really a patient with autosclerosis or not? You again look at the contour that I mentioned and look at it here. If you see a convex contour at the oval window, that indicates to you that this patient has an autosclerotic focus. And this typically has to be done at the bulge, at that line of the cochlea where you see both the middle and the apical turn. So this is one sign that one can really pick up, and very sensitive to pick up early cases of autosclerosis. The other one where they've looked at is the thickness of the bone lateral to the cochlea and up to the medial part of the middle ear. And if this bone thickness is more than 2.3 millimeters, it again indicates to you that there is a focus lying over here. So it would be nice for all of us to speak to our radiologists and talk to them about this, because if they can do this, they will be able to increase their sensitivity of reporting on autosclerosis. The one thing that has to be underlined here, as all this imaging has to be done on high resolution and has to be multiplanar imaging, we would advocate that you use a 128 slice CT scan, only because it picks up these minor changes much better than, let's say, the older CT scan machines. A lot has been spoken about cone beam CT, and yes, definitely the two advantages that it has is that it has a lesser acquisition time and it does have lower radiation. The images are very, very good. And over here, you can even see the facial nerve lying over the round window niche, very well demonstrated here. And over here, you can actually see the autosclerotic focus. You can see the incus long process, the crura. So a very well-defined images on CBCT. The challenge here is that for the cone beam CT, we cannot use the same machines that are available right now in almost every nook and corner. That's the dental cone beam CTs. We need dedicated temporal cone beam CTs to be able to get these images. And what I think, since we don't have a cone beam CT here in Pune, the images that we are able to get from an HRCT, I would say, are almost equal, definitely not better, but almost equal to what we are seeing in this slide from the cone beam CT. Even in the cone beam CT, one has to remember that the sensitivity of diagnosis, again, is dependent on the stage of the disease. It is more sensitive to pick up the autospongiotic stage than the autosclerotic phase. And that's something that we've got to remember when we send our patients for imaging. The important thing about imaging, and I think, is the fact that, as Manoj mentioned, it's very important in imaging to be able to remove the possibility of a patient having a third window. And my topic today does not really, involve me having to talk a lot about this, but what one must remember is that the third window and autosclerosis may coexist. And that's really important, because with stepidotomy, which is what we would plan if we hadn't done imaging, it would unmask the clinical features of the third window. The patient may have no improvement in hearing postoperatively, and there may be increased chances of inner ear damage. So a preoperative image has given us an awareness that, yes, this patient also maybe has a third window, and thereby our counseling to a patient would definitely change. Of course, audiologically, you will see supranormal bone conduction thresholds in this patient. But if you don't have an audiologist who's really up there, then there are chances that you may miss this. And this is a case report that I got, where you can see that this patient has a superior semicircular dehiscence, and the patient also has an autosclerotic focus. So very important for us to pick this up in our preoperative imaging, just to reduce the chances of things going wrong. There is, however, the false negative. The patient has autosclerosis. You and I are suspecting it both on clinical history and audiology, but the imaging is coming negative. And the two causes for that is, the first is an early infraradiological disease. Remember, the imaging cannot pick up focus which are less than 1 millimeter in size. There is a possibility that your imaging may miss it if it's that small. So if it's very, very early, then imaging may miss that. But what's more important is something known as non-autosclerotic Stapes fixation. And for me personally, if a patient has clinical and audiological features of otosclerosis and I am getting negative imaging, I am worried. Because this is a patient who may have something called the annular fixation of the stapes. And it is in these patients that the incidence of foot plate related complications like mobilization, fractures, floating foot plate are very, very common in this. So if a patient is negative on imaging, it's actually something that I am a little more stressed about when I am taking this patient up for surgery. When we look at how imaging impacts our surgical plan, I would put it down to these 5. It gives me an idea of whether the patient has an obliterative foci, seen as high in about 33%. If the patient has a facial nerve dehiscence, already spoken about by Manoj and even by Professor Muller, a narrow oval window. If I know that exists preoperatively, I am planning accordingly during surgery. I know I've got to drill a lot more on the promontory. I've got to keep prostheses which are thinner in diameter in my OT. The risk of a CSF gusher changes everything completely. Are we going to really go ahead with the surgery? If you're going ahead with the surgery, are we telling the patient what can happen? And intraoperatively, you need to be prepared to handle a CSF gusher. And a persistent stapedial artery, which for me at least is more theoretical because I've not had the experience of seeing one in practice. I'll just quickly show you some images here. The yellow arrow here is pointing to a biscuit foot plate. Look how thick the oval window is. Look at the thickness here. It's completely filling the oval window. Here we know now, we've got to be prepared. One, time is going to be more. We've got to be prepared for a lot more drilling. And most importantly, the length of your prosthesis, maybe in these cases, you're going to need a much longer length. So all this, if I have this information preoperatively, it's just giving me a better idea on how to go about it. Facial nerve dehiscence you have over here. Again, the green arrow is showing you the facial nerve. The blue arrow is showing you the oval window. Look how much this facial nerve is covering the oval window. Am I going to even give this patient a chance for surgery? Something I've got to consider. You look at the next cut, same patient. This is completely covering the oval window here. So again, do we go ahead? Do we not go ahead? I know this preoperatively. This is not something like an oops situation that I'm going to have to face on the OT. Another patient of a dehiscent facial nerve, but look at the dehiscence here. This is the dehiscence. This is the oval window. I do have some space here. So preoperatively, this patient, I know, yes, I can give this patient a chance and maybe insert a thinner piston here. So this, again, imaging is telling me this preoperatively, I'm better prepared for it. Again, the same thing. This is just a video to show you the same thing I think Manoj showed you. This is the patient in which you can see the facial nerve is completely covering this oval window. I have just no space here to put in a piston, and we abandoned this patient. This patient is not mine. It was operated somewhere else, but I got the imaging. I'm just sorry that we didn't insist on an imaging for this patient preoperatively. If we had, it would have saved both the patient and the surgeon a lot of grief. A narrow oval window. Look at this. This is the oval window. Look how small it is. Again, look at the blue arrow. This is an extremely narrow oval window. I've got to know that I will not be able to maybe put in a 0.6 diameter here. I might have to put in a 0.4, and I will have to make space. I will have to drill a lot of this bone on the promontory to get access here. Again, all this just making my surgical planning much easier. For imaging signs for gusher, these are the 5. If any of these are there in the imaging, give a rethought as to whether you want to give this patient a surgical option or you want to give him an amplification device. An absence of a bone structure between the cochlea and the fundus of the interaortic canal, a large vestibular aqueduct, any sort of cochlear dysplasias, especially associated with the deformed modulus, the enlargement of the labyrinthine segment of the facial canal. This is one of the signs which maybe is missed by most radiologists, and an enlarged cochlear aqueduct. So any of these 5 exist in your patient, it's a red flag. For persistent stapedial artery, like I said, I've been fortunate never to have it. But again, in imaging, if you've got an absent foramen spinosum, an aberrant ICA, and a soft tissue swelling below the tympanic segment of the facial nerve, a red flag. Am I going to go ahead and do a surgery? Is again something that you're going to have to think about. The next thing is a classification based on radiology, and we have 3 classifications. You have the Simons, you have the Rottweil, and the Vallon. We use the Simons. How does the classification really help us? It really helps us to know which is the patient you're going to be able to sort of counsel about outcomes. If I have a patient who has a grade 2, almost, let's say, B, then I know this patient has also retrofenestral autosclerosis, and in which case I am going to be counseling them that, look, surgery will help you to some extent, but it's not going to be the be all and end all or the last solution for you in terms of your hearing. Just quickly, we'll show you some images. This is a grade 1, a very, very small autosclerotic focus just on the anterior side of the oval window. You can see it here and you can see it here. So this is grade 1, which says it's just involving the fenestral region or the region of the oval window without involvement of the cochlea. This is a grade 2A with a narrow oval window. So you see the oval window really narrow, and look at the involvement of the autosclerotic focus. It's extended onto the basal turn. Most importantly, also start looking here. It's starting to cover the round window. Now, this is important because if you have an autosclerotic focus that's also covering the round window, you know for a fact that your results are not going to be as perfect as others. So imaging has helped me here preoperatively to tell me what's happening beforehand. Grade 3 or advanced autosclerosis, characterized by what we call the halo sign. So you see this radiolucency, which is completely around the entire aortic capsule. You have ossification intracochlear, and this is the sort of patient in which you are going to, of course, follow up with an MRI also to know cochlear patency. When we look at post-op imaging, the only indication for post-op imaging is in a patient with a poor outcome. It's not done routinely. It's not something that we would even advocate to be done routinely. In any patient with a poor outcome, depending on whether this is sensory neural or a persistent conductive, what I want the radiologist to tell me is what is the position of the processes. I want to know what's happening to the long process of the incus. Is there some sort of a granuloma which is sitting on the oval window? Is there any evidence of a perilimb fistula? This is the 4 most important information that I want from my radiologist to tell me so that I can decide as to what is my next line of management. Just to give you some idea of some post-op images, this is a patient who has a right-sided piston. This is a cone beam CT. Notice that it's protruded a lot into the vestibule. This is a patient that post-operatively is presenting with persistent giddiness and is not resolving. You know this is showing you that you've got to go back, redo this, put in a shorter piston, and maybe if the patient has an associated perilimb fistula, also deal with that. So this is something where immediate post-op, it makes a big difference to us. This is just to show you what a normal ossicular prosthesis would look like on an HRCT. So you're seeing the incus, you're seeing the prosthesis well fitting on this and just touching the vestibule. Again, over here, nicely hooked onto the incus and just up to here, touching the oval window. Again, on this image, one gets a feeling, oh, it's a little short. Remember, go back, sit with them on their console, and you will be able to see whether this is really touching the vestibule or not. But when I look at this image, I remember my initial reaction was, oh, I think this is a shortened prosthesis. Now to show you again HRCT pictures that can tell me what's really going wrong. Look at this here. Remember what I showed you in the previous picture? This is not at all in touch with the incus. Look at it. It's fallen. It's fallen more posteriorly. We know for a fact it's not really touching the vestibule here. So this is a patient whose prosthesis has fallen off the incus. It's lying outside. It's fallen into the middle ear, and we need to go back and do something about it. This is a classical oops situation. This has just completely immersed itself into the vestibule, And this is a patient that unfortunately had complete sensorineural hearing loss, and one can see that and understand why that's happened. A reparative granuloma is a challenge again for your radiologist, and he or she should be sensitized about this, because a lot of us do keep some soft tissue around the fenestra that we make, and most of us use fat. It's important that the radiologist knows the differentiation, because fat does not look like this. This looks like a soft tissue here. This is a reparative granuloma that was picked up. This patient was operated 2 weeks ago, not doing well, having a lot of tinnitus, giddiness, no improvement in hearing, and you can see this soft tissue lying around the prosthesis. So again, something which imaging picks up for me preoperatively, and I can go and see. The role of MRI is very limited. And as far as we are concerned, it's really indicated in only 3 areas. Imaging in far advanced otosclerosis to establish cochlear patency, see the extent of cochlear ossification. If clinically you're suspecting that this patient also has a concomitant endolymphatic hydrops, then MRI helps us with the Meniere's protocols to pick this up. Post-operatively, and this is something which is still not done so often, if the patient has sensorineural loss, but your HRCT imaging is showing the prosthesis is in place, but there is no other thing that you can find in the HRCT, MRI may give you a clue as to what's gone wrong. And what the MRI might pick up for you is that you have caused a bit of labyrinthitis, could be serious, could be the fact that there's been some amount of an inner ear hemorrhage, blood has trickled into the vestibule, caused damage, and sometimes you can even get an intralabyrinthine repair granuloma. So the role of an MRI, I think, is still limited, but especially post-operatively with an HRCT normal, I think if the patient has an SN loss, we should start looking at doing MRIs to maybe understand what it is that's gone wrong. This is an important thing, and this is more a tool more than something that's really going to give us much information. This is a paper that came from Arun Gadre. It basically just involves a radiologist to press one button on the console, and you're actually able to see images which can tell you the thickness of the foot plate. So very nice tool that can be used where you can see the differentiation in the anatomy, and it's called the grayscale inversion. But like I said, it's more an academic exercise than really something that we've been able to use as of now with some practical implications. But that's as of now, we don't know what's going to happen going ahead. I think that's about it from me. Thank you so much for your patient listening. And I take great pleasure to invite you for the 20th CGCon of 2023 to be held at Chennai, India. Thank you so much.
Thanks so much, Nidam, for that exhaustive presentation. We went a little bit beyond time because we have combined these 2 talks together, that is imaging before and after, and also immediate management of complications, which was also covered. So now over to Professor Mohan Commission, who will tell us from his vast experience and wisdom how to prevent complications in Stapes surgery. Professor Mohan.
Thank you, Manoj. Are you seeing my screen?
Yes, Mohan, very clear.
Okay. Yeah, well, it's a very important panel, I think, this particular topic today. And preventing complications is what all of us want, and every surgeon wants. Certainly, Neelam's talk, I think, highlights most of the important things, because we can generally predict most of the problems radiologically, even prior to going in. And anticipating the difficulties means that you avoid the complication. But then not always this is possible. You know, even though we have excellent tools today, sometimes even those are not important. And we do see, you know, when we open up that there are difficult situations. And then I think the only thing which prevents complications in those situations is the surgical technique itself and the experience and expertise of the surgeon. and to have a strategy for managing this. So I think meticulous surgical technique really, as Professor Muller said in his talk, and Manoj also said in his introduction, I think this is really the crucial thing for preventing complications. So generally, already this has been discussed, the various complications in Stapes surgery. One of the worst complications I ever faced was a facial palsy for no apparent reason. A patient had an excellent surgical result, did not even have a decent facial. There's quite a lot of space. Postoperatively had a facial palsy, which lasted for a good 4 to 6 weeks, I think. I still haven't been able to explain it, but there you are. So you can have complications even with the best of intentions and avoiding every possible problems. But you know that this nerve is fine and is going to recover. Maybe there's a viral activation or whatever, but you know that the nerve is anatomically fine. So sometimes, in spite of your every precaution, you can face complications. But then, complications are a way of life, which is why surgeons live much shorter lives than physicians. So, we have to learn to live with it and cope with it. So some of the difficult intraoperative situations, I think I'll start off with a narrow extraordinary canal. I do stepidotomy through the canal, so transcanal stepidotomy, and I've been doing for the last 42 years. So I have very, very rarely had to resort to endoral or a postoral approach for doing that. For me, narrow canal is something I assess in the outpatient. When I see the patient, I always subconsciously look at the dimension of the external canal. And sometimes you have a very prominent concha, which is itself partially obstructing. So this is something that you can deal with, but as we'll talk later. But basically, this is something that you assess even before you actually post the patient for surgery. The overhang facial nerve, basal nerve, floating, all this has been touched upon, versus septal artery also, and obliterative aortic sclerosis. Now, this is the narrow canal. It's a very, very the smallest speculum, pediatric speculum that I'm just putting in. So, how do I deal with this problem? Either you can do a endoral like Joachim Muller showed us, or what I do is, these are the sort of situations where a general anesthesia is very, very helpful, because you can then do a serial dilatation of the explanatory canal. What do I mean? Use graduated speculums, gradually widen, and then till you get a reasonable, decent-sized speculum. This is what I did in this particular case. So I used successively larger speculums, dilating the explanatory canal. But this is only possible under GA, because otherwise it's very, very uncomfortable for the patient. So this is one situation where a GA is definitely helpful. Overhanging facial nerve, people have talked about it, and you can see here, this was predicted preoperatively, like from cone beam CT, we could see that this patient got a overhanging facial nerve. And I'll just show you what I did. I've never actually abandoned a patient ever because of an overhanging facial nerve. So very narrow space between the facial and the crura. You can see the situation there. So I'm taking the posterior crust out, and here when you're drilling, you're not coming from above, but going from behind the posterior crust, which means you have to take a little bit more of the overhang. So you have thinned out the posterior crust. I have done that. And then, of course, I cut the tendon, so I can't do a control fenestramium before like I normally do. So I then drill the superior part of the promontory. So you have a lot of space below the oval window and in the upper part, the upper lip of the promontory, because the stapes is, you have the vestibule extending into that space. And that space you can do. Only thing is, when you're using the piston, introducing the piston, it's going to go into the lower part of the incus, and this will have to be adjusted a bit, which means that the stem of the piston will be probably in contact with the facial nerve. And therefore, when I usually use a bit of fat to seal off, and then this fat has to be introduced between the stem and the facial nerve. So this is a floating foot plate. So what I've done is I've tilted, I've pushed a little bit of the anterior part, and then this posterior lip lifts up, and I'm putting a very small little hook underneath, and then moving it forward. This means, of course, almost certainly a total staphylectomy. But that's not such a bad thing, and I've seen enough people doing total staphylectomy over the years, getting good results. Of course, we don't want to do that, but if that happens, you don't have to despair. Just make sure you get a very good seal all around the piston and seal it off. So it doesn't mean that the patient is going to go in for a cochlear loss. You can have very good results with total staphylectomy. I've seen, as my mother said, Professor Subramaniam doing it routinely. My father used to do total staphylectomies routinely. And I think I've seen them all doing it for years and years with very good results. Perilymph leak or an active gusher, it's not a very big gusher, but you can have this kind of thing coming. This patient had normal anatomy. I mean, there's nothing to suggest that he's going to have a gusher, but it only means that you don't abandon the procedure. You go ahead, you put the piston, get a good seal all around it, wait for the leak to stop with the seal. Fat is a very good material for plugging because for several reasons. Fat, is liquid at body temperature, so it sort of oozes around and seals off. And then you can use a bit of tissue glue if required. But basically, fat, is good. But make sure that the leak stops prior to your getting out to the OT. This is a revision surgery, and revision staphylotomy is always a difficult situation. You have unexpected problems. Here, a facial nerve is dehiscent and it is prolapsing over the, the whole window. But again, as I said, you move down a bit towards the promontory, create a fenestrum, and then introduce your piston. Use a bit of soft tissue between the stem and the facial nerve, so that your nerve is protected from the piston, right? So this is it. The here is an incus, which is a long process is absent completely. So using a piston from the malleus handle to the fenestrum. So a maleo vestibuloplasty or a maleo platinopexy. This is never a happy situation. It's never going to give you the same kind of airborne closure that you get when you put it onto the incus, for the simple reason that the trajectory of the piston is wrong. And the transmission of energy, acoustic energy, is never going to be perfect, unlike when you hook it onto the long rows of incus. But under the circumstances, you can get a good hearing results in many. How long it will last, as Professor Muller said, over the many years of follow-up, in over 15, 20 years, gradually you will find that the hearing deteriorates after 10 to 15 years. So this is one of the problems that you might have to accept. This is a patient who had revision staphylotomy again, had a persistent conductive loss after the surgery. He came to me he was sent to me by the original surgeon about 2 years after the original surgery. So he removed the piston, and then when you look at it, you can see that the piston was too short. The fenestrum was never made. I think Joachim also talked about this. Have you drilled it at all the first time? So here you can see that I'm making a fresh fenestrum. This we predicted prior to surgery by the cone beam CT. We thought that this might be the case. And then I could go ahead and do a fresh fenestrum and then introduce the piston, and the patient happily had a good result. Unfortunately, I don't have a video for the persistent epilepsy, but I've seen a persistent epilepsy on 3 occasions. Unlike what has been told to you, it's not such a terrible thing, really. Persistent epilepsy is always submucosal in the middle ear. It goes in front of the round window over the promontory and emerges at the inferior lip of the oval window. Of course, preoperatively, you can predict it by the absence of the foramen spinosum, as Neelam said. But you can easily cauterize this artery. It's not such a difficult thing. Ideally, keep a little bit of a gel foam bridget with adrenaline over the artery, before you do anything to it. You can identify the pulsatile artery going between the crude of the stapes, and then you can cauterize it inferiorly from the oval window over the promontory is probably the best site to cauterize it. You can keep a little predjet of attendant invariably to stop. So it's not as bad as it sounds. You don't have to abandon the surgery because of that. If you can put your piston, behind the septal artery, sometimes it's possible that you have a little bit of space behind septal artery, then you don't have to disturb the septal artery at all. You can go even behind it. So it's not always a situation where you have to abandon the surgery. Right. So with that, I will stop. So basically, I would like to summarize by saying that good technique and anticipating the problems with good technique is what would save the day when it comes to preventing the complications, even though you may have a lot of information preoperatively from radiology. Not always do you get all the information, and you must be prepared in every case to face the challenge. Thank you.
Thank you so much, Mohan. That was a very extensive discussion on all the difficult situations one could face in Stapes surgery. That widening with the speculum, very nice trick, Mohan. I like that a lot. We generally tend to put endoral, but I think I should try this next time. Amit Kishore is a head of department of ENT at Apollo Hospital in New Delhi. Very senior surgeon. He's been a teacher in the UK. Very experienced cochlear implant surgeon, and does a lot of mid-linear surgery, does brainstem implants also. Amit will be talking about how technology has helped us to do better in otosclerosis surgery. Amit, over to you.
Good evening, everybody. Am I audible? And
clear. You're audible and
my screen.
Your screen is seen. Yeah.
Wonderful. So thanks to the Indian Academy for this opportunity. Thank you, Manoj, for moderating and getting me on this. So without further ado, we've heard some very, very good talks, and thank you very much to all the previous speakers for laying down the foundations for this. So basically, I've been asked to highlight the role of technology that might help us reduce complications, because we've heard very, very extensively about the importance of surgical technique and also prevention of complications better than trying to sort it out later. So Dr. Neelam has very beautifully already taught us about the first bit of technology, and that is imaging, and primarily the role of CT and sometimes MRI in the preoperative assessment and planning of patients of otosclerosis. So that's the first bit of technology, is imaging, and I agree. I for a number of years now, unless there's an exception, some specific reason, always ask for a CT scan on my patients with otosclerosis where I'm proceeding for the stapedotomy. The other bit of instrumentation comes intraoperatively, and I think one of the most crucial steps in the intraoperative phase is the fenestration, and that's what we will talk about in terms of technology here. So yes, we are all familiar with the standard technique and the use of a hand trephine or a perforator to make this fenestration, which works fine in many hands. You've seen Professor Buller do that, and lots of other experienced surgeons do that too. But nevertheless, we do have technology available. And the two bits of technology that we have available to do this safer and better is either the micro drill or the use of a laser, as you've heard already. So what I've done, I've tried to put in a little bit of the evidence that is available as per date based on the literature and supported by 2 videos. So when we look at the fenestration, we've got the micro drill, we've got the laser, and there was also a piezoelectric device that came out to allow for this step. Now, very, very quickly, I will share with you that the piezoelectric device is something which has been fraught with problems and is not advised, because the use of the piezoelectric device, which produces a lot of vibration, has been shown to provide or cause the maximum drop in bone conduction post-surgery and the maximum amount of post-operative vertigo. So that's something that is not visible is the piezoelectric device to create a fenestration. The micro drill and the CO2 laser in this particular study from Italy came out to be very similar in terms of these two outcome measures, be it a change in BC thresholds or post-operative vertigo. So the micro drill, you can use various types. The skeeter is something that most of us, those who use drills here in our part of the world, use a skeeter. You can use a micro tab from BNA or whichever other micro drill you can, if you wish to use. I find it very, very useful tool, and ever since we've been using the micro drill for years now, I'm much more comfortable with that to make the fenestration, and even if necessary to fracture a very, very thick, a very, very thick crura before fracturing it. Yes, sometimes, so that's the way we would prefer, is a reverse technique, like Manoj has mentioned, that before we fracture the crura, we would like to make the fenestration because everything's in place and you have better stability. But sometimes if it's very tight, then I would use the drill to give myself more space, cut away the posterior crust of the stapes, and then fracture it down and get more space, and then go ahead with the skeeter to make my fenestration as you would normally do. So that's the micro drill that you can use, and it comes in various sizes of diameter. Let's move on to the lasers. So the only thing you have to be careful about the micro drill is that yes, it's possible to take the drill and to go through the foot plate and into the vestibule. And if your foot is still on the pedal, then you will very, very quickly churn away all the endolymph and all the fluids within the vestibule like an egg beater. And I think that's the end of the hearing of that patient. So it's something that has to be learned, and it goes a lot by not just by vision but by feel. And the moment you feel the give and the loss of resistance, that's when you stop. And it doesn't harm if you take it bit at a time with maybe some adrenaline soaked gel foam, if you like, if it's been bleeding, to make sure that you are not through the foot plate. Lasers. So lasers have been around for a while, and as Manoj just said, yes, Rod Perkins introduced that many years ago. So I remember about 20 years ago when I was training, I was exposed to the argon laser and then the KTP that we had in the UK. The erbium YAG came out, then the carbon dioxide lasers come out. Then here we use the diode, and now there is a thulium laser. So there are a variety of lasers, and they have different wavelengths, as you can see. So the argon, the KTP are in the visible range lasers. The carbon dioxide is an invisible range laser, and you need to use a helium neon aiming beam if you want to use the carbon dioxide laser. They all have different properties. So the visible length lasers are absorbed by hemoglobin, cause charring, whereas the invisible length lasers are absorbed by fluid, and therefore the collateral damage is much less with the carbon dioxide laser. And each of these has been described and used over the years in Stapes surgery. And this is an example of a diode laser that I was using maybe a couple of years ago. And the advantage of the laser is that you have minimum or no touch. You can use a laser to divide the crura, so you're not really using the drill to create vibration. You can even by feel thin out the anterior crust. It will cause charring, of course. And once you've done that, then you can free out the crura, and then you can use the laser to create the fenestration. If you're using a visible length laser like the argon KTP or even the diode laser, because there is more tissue penetration, the principle here is to create a rosette of burn on the foot plate. You do not go through the foot plate with the laser. It works in contact, and you have to have a little char at the tip of the laser. You use a 200 nanometer fiber, and then once you've thinned out, you've coagulated. One good thing is that you can coagulate the vessel so you don't get bleeding. Once you've thinned out and charred the foot plate, then I would always use a perforator or a micro drill to make that final opening. So when you're using a visible length laser, we do not go through the foot plate with that laser because that heat is going to cause intracochlear damage. So let's look at the evidence. So we've looked, so there are a collection of papers which I'll summarize. So you've got a comparison of the carbon dioxide with the thulium, we've got KTP with the carbon dioxide laser, And the carbon dioxide, one of the disadvantages of the CO2 at one time was that it could not go down a fiber. So you had to use a micro manipulator. And the one-shot technique has been described. But now the CO2 laser is also with the Omni guide available on a fiber enabled. So if you are somebody who likes to use the fiber, then you can have that through the fiber enabled CO2 laser as well. One of the worries about the laser, like we talked about, is heat transmission, post-operative sensory neural loss, and vertigo. When bone conduction was measured after Stapes surgery and compared the CO2 laser with the manual perforation in this paper in Germany, they looked at the fact that there is actually statistically no difference in the bone conduction changes between these two techniques. So if used carefully, you will not necessarily cause change in sensory hearing loss post-operative. Looking at the thermal, mechanical, and acoustic properties of the diode laser, which is a 980 nanometer sort of partial visible length laser in stapedotmy, and they compared the KTP with the diode and the carbon dioxide and the micro drill. And in fact, as you would expect, the drill did produce more acoustic noise as compared to the lasers, because the lasers are not going to produce noise. They will produce more heat, and the drill will produce a little more noise. But in terms of outcomes, if you use carefully, it was not. It didn't have any negative impact on the outcomes of that Stapes surgery. But that's something that you have to keep in mind, because if you are not very careful with the micro drill, then you can create a bit of sensory hearing loss because of the noise factor. And if you're not very careful with the laser, you can do the same because of the heat. A systematic review which looked at over 300 articles, and they only found a handful of articles actually that met the criteria for a systematic review. But they looked at these various papers that looked at the KTP, the erbium YAG, carbon dioxide, and diode lasers, and they looked at bone conduction changes, sensory hearing loss, AV gap closure, vertigo, and tinnitus. And actually, it was quite comparable. The erbium YAG is something which is not advised. That's something urologists use. There's a lot of acoustic energy that's delivered from the erbium YAG laser. So the neodymium YAG, the erbium YAG, and the thulium lasers produce a lot of acoustic noise. So these are lasers that are not to be used, but the visible length lasers, to repeat, the KTP or the diode and the carbon dioxide lasers can be used safely if you know what to do with them. So the hearing results are comparable, and you don't necessarily cause any significant damage. But one area where lasers, I think, are very, very useful is in revision surgery. So we have access to the laser, we have access to the micro drill. A lot of the time we're just using the drill. Sometimes I take out the laser if I need to. But if there's a revision situation, I think this is one situation where it would be, I can't say mandatory, but it's highly desirable, because you have all the soft tissue, granuloma. You've seen some lovely videos of various difficult situations, and you're trying to pull out that prosthesis. There's lots of adhesions around it. So I think if you have the laser to your availability, then you can vaporize all this tissue, result in minimum mechanical trauma when you're trying to revise that situation. So that's something that I would certainly commend, and the literature suggests that as well. So to summarize with the lasers, you've got the visible length lasers and argon KTP. They are absorbed by hemoglobin. Penetration is higher, so you will use it to take away the crura. You'll use it to create a rosette on the footplate, but you will not use them to make the final penetration. And the same thing with the diode laser. The carbon dioxide laser can be used as a single shot or with a fiber, and then yes, you can use that to make the fenestration, because it gets absorbed by water, and it doesn't create a lot of thermal damage. Tholium, erbium YAG, neodymium YAG cause acoustic shock, to be condemned, never to be used in Stapes surgery. Advantages are no touch technique, minimum movement, and trauma, and therefore you have this advantage certainly in revision surgery. The last bit is when it comes in terms of technology, is the types of prostheses and various materials and shapes and sizes. So we've seen some of that, and Professor Muller has also alluded to that. So we've got the Teflon, we've got the titanium and various things. You've got combination prostheses, you've got litinol prostheses. Now, and there was gold at one time. So the literature suggests that as far as acoustics or reaction, apart from some of the older plastic materials that Professor Miller has alluded to. In terms of audiological measurement, there is no difference. You can use what works best in your hands in terms of the acoustic measurements when it was on models. However, one factor when it comes to the prosthesis is the point of fixation, and this again has been alluded to. So this will have an impact on your outcome. Now that depends on the technology used and actually what works best in your hands. What has been seen and has been shown by the likes of Alex Hubert and Zurich and lots of others is that crimping or fixation of the prosthesis onto the long process of incus is a very critical step and a critical point if you're looking at post-operative airborne gap closure and conductive hearing levels. And you can have losses from 3.5 to 20 decibels if you do not have firm crimping and you have a loose wire or a loose piston syndrome. And again, like Professor Muller has mentioned, you have with that movement over there, you can have erosion of the fixation of the prosthesis. If the prosthesis is touching the aortic capsule bone and there is movement of the incus, that will slowly and steadily cause erosion, apart from the avascular necrosis that is the other side. So fixation is important. Now this depends on your technique. So a lot of us use the Teflon prosthesis, works extremely well for me. Like I said, if you're a winning team, you don't need to change that. But as far as technology is concerned, a quick word about the self-crimping prosthesis that was mentioned. So yes, you can have titanium, which you can crimp, and the nitinol prosthesis or modification of the nitinol prosthesis that has been described. And the nitinol is a combination of two alloys. And the idea is that when you deliver heat to the nitinol prosthesis, it will self-crimp and close over onto the long process of incus, which you have already seen. And the idea is that you have the early studies did suggest that the nitinol prosthesis provided better airborne gap closures. And then you've seen this already, and this again I'm quoting Professor Mueller's paper himself, where they have the smart, where this sort of prosthesis again made of nitinol in different shape, which provides better fixation. And again, when you deliver heat when it was compared over the titanium and the clip prosthesis, it seemed to give better airborne gap closure using this particular prosthesis. But works better in the non-experienced hands, but if you're experienced, then probably it didn't seem to make a big difference. But for the novices, maybe because crimping can be a breath-stopping time during the surgery, so that's something that you can think about. But I still I'm very happy with with my Teflon prosthesis, and I just take care to not to use a good quality Teflon prosthesis, not to overextend the loop, and then to use the angled crimping forceps to very gently and firmly crimp it onto the incus. And that works well for me, and then I check the mobility and position it right. So that's as far as technology from the piston point of view. So I think I've tried to stick to the time allotted. So to summarize, when we're looking at technology and how does this assist us, CT imaging, we've heard about that very, very well, and certainly recommend that both from diagnosis and picking up the red flags. Instrumentation during surgery, yes, the micro drill and the lasers, both of them are tools that can help us minimize complications and get better results. In revision surgery, laser certainly has a good role. And a quick word, we've talked about the various materials and pistons that are available, and the fixation of the crimping of the piston onto the long process of incus is an important point when it comes to the results. So all these little things put together to help us minimize complications and maximize results. But finally, while we are talking of technique and technology, I think, as has already been alluded to, and Professor Kameswaran has very rightly said that there is nothing, technology does not replace surgical technique, attention to detail. That's so very, 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 very important because at the end of the day, a fool with a tool is still a fool. So even if you have a laser, it doesn't make you a better Stapes surgeon if you don't have the right technique. So thank you very much for the opportunity, and I hope I've been able to cover what I was asked to manage.
So thank you so much, Amit. That was a very exhaustive discussion on the techniques that you use, the pistons, the lasers. And glad that you put everything in perspective, which laser is good and which laser is not good. So meanwhile, we'll just go on directly to our panel discussion. Now, we have heard about from everyone. We heard what Professor Muller said about long-term outcomes. We heard from Dr. Neil Ahmed about how to look at radiology, look at preoperative prevention of complication and postoperative management. Professor Kameshan about what are the techniques that you can do for preventing complications and avoiding them. And of course, Amit and how technology would help us to prevent complications. So now we shall address all of them. I hope all of you are here. Amit, I can't see you. Professor Mohan. Yeah.
Very much here, not run away.
Shabir.
Yes.
Shabir and Dorwala, you're here?
Manoj, I'm here.
Good, good. Fine. So now we shall deal with each one of you. Let me just ask Professor Muller. You mentioned that you tend to use the endoral route always. Professor, is that a thing? You do not use speculum holders? Can you tell us why? Because a lot of people actually use speculum holders a lot.
Well, I do hope you can hear me.
Yeah, we can hear you, Professor.
I could not understand properly the first part of the question. There was a little bit noise, and I want to make my computer a little louder. But
in a very narrow canal, and if you do not see the entire drum, would you like? Why would you? I mean, you said that you always use an endoral route, right?
yeah, we always use the endoral approach for a reason that we want to see and have a little bit larger access. However, this is a minor procedure, and I'm not sure if it makes a difference once you do it transcanal, if you're experienced to that, or you do it end-orally. The end-oral approach and the incision goes back to Hermann in Essen from the early 60s.
Yes.
So this is a pretty much German thing, that this access is used in other aspects for tympanoplasty as well. So this is.
So I think even I would also, even when I am teaching, I'll tell people that when you're starting off, always do it endorally because you always have both your hands free. Is that what you mean, Professor?
Yeah. And we put two retractors inside, and that keeps the entrance largely wide, and you have two hands free for.
Dr. Neelam, what would you use all the time? Is it always a transcanal or endoral? Neelam?
It's usually always a transcanal, except a couple of cases if the external canal is really narrow. I would say in just about 1% I have converted to an endoral, but it's mainly transcanal.
Shabir, you've been quite, I know you've been busy, otherwise you would have given a talk also. But you always use a transcanal approach for all, even your tympanoplasties. So there's no surprise that you would always use it for Stapes. But we ever had to change, ever?
No. On one or two occasions, I have taken endoral incision essentially because there was an overhanging cartilaginous portion which I could dilate. The cartilaginous portion was very narrow as compared to the bony portion. You see it sometimes. And in those cases, endoral incision really widened out the canal very well.
Mohan, we saw your description of widening the canal. I think that's what Robert von Sand also uses. Would you, have you ever had to use a post-oral, and do you advise people to use a post-oral approach if it's very difficult?
I think maybe just once or twice, if I recall, probably once, I think, a very, very narrow matrix. But I agree with Shabir. I don't think, you need to go in. Transcanal is almost always possible. As I said, if you are having a very narrow canal and you expect that you may have to dilate it, then I would counsel the patient for having the procedure under general anesthesia because it's more comfortable for the patient.
Yes, yes. Amit, in England, I'm sure they've been using speculum holders. Have you ever had to use one?
Yeah, Manoj, there people use different techniques. That people use the transcanal with and without speculum holders. So both options are available. I personally have always used the endoral technique.
Okay.
That's just the way I was trained, because my mentor was a student of Lester himself. So so I've been trained. So a lot of my techniques are following the
Endoral.
German school.
Okay.
So I always use. I'm just comfortable with that, and I've not bothered to change.
Okay. So endoral, I think, is a very versatile technique, and it's I mean, you hardly see the scar, there's no pain, and you get your both hands free. So I'm sure that I would personally recommend it to people. Now, Shabir, there is a patient who's got autosclerosis. Then we look inside, you find it's a very, very thin drum. Would you proceed with autosclerosis, or would you stage it?
Yes, Manoj, this is really interesting because once upon a time, I mean, say 20 years ago, I would see autosclerosis with normal drums. But for whatever reason, today I see a lot of autosclerosis with thin drums,
It's true.
Whether it is coincidence or what, I don't know. Mohan, what do you say?
Yeah, certainly see this quite often.
Yeah. So we have divided, I mean, this is our division, this is not in literature, that a localized thin drum, which is a posterior superior region where we will be working. If that is the one, then I would proceed with surgery and put a perichondrial graft under the drum.
Okay. No cartilage?
If there is a thin drum anterior to malleus handle, I wouldn't bother about it.
Okay.
But if there is a thin drum which is almost global, then of course I will do a regular tympanoplasty first, and then go around.
Stage it. Okay. Stage. Neelam, you're operating for a completely dry central perforation, and as you're operating, you find that there is autosclerosis. Would you stage it, or would you want to do some? It's a totally dry central perforation, no disease, healthy medial mucosa. What would you do?
I would stage it, Manoj.
Can you tell us why?
I just don't want to take that risk of anything going wrong. I agree with you that it's completely dry and there is no active infection. But I would rather have a middle ear which is completely closed from the external environment before I do autosclerosis surgery. It's just that even if that 0.1% chance of something going wrong, it may be a 0.1 in my statistics, but it would be 100% in that patient's life. So I wouldn't like to take that risk. And I would tell the patient that accordingly.
Professor Muller, in Germany, do you follow the same thing? Would you do these two things at the same sitting? Closure of a small population?
No, we would stage it.
Always?
Yeah.
And your preference for a very thin drum, would you use cartilage or perichondrial?
Well, depending on where in the area of the tympanic membrane the thin membrane appears, most probably we would reinforce it with perichondrium.
So, Amit, I think, do you have anything
Can I
to
say something?
No, it's just the same as what everybody else has said. And if I'm doing an endoral, perichondrium is easily available.
I mean, Shabi, I am seeing a lot of patients with very thin scars. It's also there for you also. I mean, previously, like Shabi said, it was always a normal drum. Now you find all kinds of things.
Yeah.
Do you see them?
Are you asking me, Manoj?
Oh, no, I'm asking Amit.
Amit.
Oh, I'm sorry. Yeah, I've seen a few, not a lot. We're seeing a few, yes, probably a little more than what we're seeing before, with some sort of healed or scarred tympanic membrane.
Now, again,
Manoj, before we shift, can I say something?
Please.
Yeah, I mean, this is long gone thing that I'm talking about. About 20 years ago, I had two cases, who came in quite succession, who had large central perforation. I was doing tympanoplasty. I found Stapes fixed, and I was tempted to do a stepidotomy at that time.
Okay.
On both the cases, I did it. So we had a situation where we did tympanoplasty and stepidotomy at the same go.
Same time, yeah. And what happened?
And the results were not a dead ear or anything, but they were not optimum. They were not 0 decibel airborne gap or 5 decibel gap or something.
Would you do it today?
No, definitely not.
Professor, I'm asking Professor Muller, if you find a patient who's had a stepidotomy, he's not had a good result, and then you find on table that the drum is plastered onto the prosthesis, what would you do then?
If the drum is, what is with the drum?
The drum is sitting, there's a grade 2 retraction of the tympanic membrane, and it is sitting on the incus. Would you still stage it, or would you do it primarily?
Well, that depends. I fear if I replace the tympanic membrane and do tympanoplasty that I have middle ear effusion afterwards, and then opening up the inner ear with exchanging the prosthesis and having inner ear complications afterwards. This is my fear. So if we have the retraction and we can cure it without any manipulation with the prosthesis, then I would do the tympanoplasty and reinforcement with a cartilage, a piece of cartilage as a pericondium cartilage composite graft, as it was described by Plester and Milewski. I would thin out the cartilage and check the situation around the prosthesis. Usually, if the hearing outcome is not good and you have a retraction and scar tissues, you have scar tissues from the handle of the malleus onto the tympanic membrane and the prosthesis into the oval niche. But opening up the oval niche, I would stage it.
We saw in your presentation, Professor, that you're using a lot of endoscope to examine the middle ear. If there is a retraction, would you do an endoscopic examination to find out if there's anything wrong?
No.
Thank you. Now, one of the cases that I've had a post-operative profound hearing loss has been quite rare, but was that I had opened up and they found that the middle ear mucosa was a little bit reddish. There was no pain, there was no symptom, there was no fluid. I went ahead and did a stepidotomy and landed up with a profound hearing loss. I think that was a bad decision on my part, happened about many years back. Do you think that all of you, I would start with Professor Mohan, if you find edematous middle ear mucosa, would you proceed this stepidotomy or always stage?
Definitely stage it. There's no question about it. I don't think you want to go anywhere into the vestibule with any signs of inflammation in the middle ear. Why? I'll go even more. And we talked about a dry perforation. You asked Neelam about dry perforation with absolutely normal middle ear mucosa. A dry perforation with a normal mucosa doesn't mean a sterile middle ear.
Okay.
So you definitely don't want to mix a septic field with a sterile surgery. That's very bad in principle of surgery. So definitely stage it. Nothing is lost in staging a procedure. And if you have an inflamed middle ear, you definitely want to stage it, treat the inflammation, and then go back later and do a surgery. And I think it's a much more sensible thing to do.
Do you give post-operative antibiotics more for stepidotomy surgery always?
Yeah, we have now, actually, I never used to give before, but, I was persuaded by everybody else in MUF saying that, you're trying to be over smart. So now we are giving routinely for, I think for 5 days or so, or a week maybe, oral antibiotics, they put them on cephalosporin oral.
What about steroids, Amit? Do you give steroids post-operatively?
We give intraoperative steroid.
Not post-operatively.
But we don't give post-operative unless I feel there's been a lot of manipulation or things have not gone very smoothly. Then I would give them, for 24
Is that
to
how
48
Professor, in Germany too? Do you give post-operative steroids or antibiotics?
Antibiotics I give.
You give, okay. So, and what antibiotic would you prefer? Any broad spectrum will do?
Yeah, cephalosporins. That's what I do.
See, now we talked about this overhanging facial nerve. Mohan talked about making a promontory edge stepidotomy. Professor Muller showed a bucket handle prosthesis. And I always felt that if the prosthesis facial nerve is bulging, if there is always a way in which you can give slight pressure and then move it slightly so that we are able to get a better view of the round window. I'm sorry, the oval window. Would you do that? Is it a good thing to do, to push it and then make way for it?
Yes.
I think it all depends on what is the extent. The cases that you're showing, it's not like covering the oval window in
covering,
its
yeah, yeah.
entirety. There is a little bit of a gap. In some cases, it covers the entire oval window, in which case I think manipulation of the facial is a lot in those cases. Also, I think the choice of piston here will be definitely thinner than the one that maybe you normally use. Like I said, from a 0.6 mm, which is the one I use, I might go down to a
0.4. I think I've used a 0.4 here.
Yeah. Also,
you-
I think
you
this is
mentioned,
the sort of
Neelam-
patient I would give a steroid, definitely. I mean, I do anyway routinely give steroids, but this is the one that will get steroids post-operatively because I
Always.
am anticipating some edema to happen around the facial.
Mohan, you mentioned about post-operative facial palsy, and there's been papers about viral reactivation in autosclerosis producing facial palsy. So could that have been the reason in your case?
Yeah, I think so. They always talk about the seventh day policy and so on. But Manoj, coming back to your original question, I think about this overhanging facial nerve, we need to actually grade it, although I don't think there's a grading, but I think we need to grade it, whether it's covering about 25% of the foot plate, 50% or 100%, it makes difference about how you're going to handle this. Because if it's a complete 100% coverage, then your situation is very different from a 25% coverage. So just an overhanging facial nerve, it's a very broad term, and I think we really need to subclassify it, when we are dealing with it. But having said that, I don't recall ever abandoning a Stapes surgery because of an overhanging facial nerve. So I think this is my point I wanted to make.
In a anomalous facial nerve running
Yeah, that's right. That's the thing.
Stapes is a condition that I would abandon.
Yeah,
Right?
Manoj, I had a very interesting situation once where I had a bifid facial nerve enclosing the the oval window. A part of it going above and a part of it going below.
Yeah, that's what I have abandoned one like that.
Yeah, and I did a septotomy. I made it in between the two. I put the piston, and interestingly, the patient was my own anesthetist. And I survived, and he continued to work with me. So it's possible. You can do it, but these are all tricky situations where today with cone beam CT and with high resolution CT, I think we can predict all this. Yes. Yeah.
Now, we mentioned about this. Professor Muller, have you used a laser to manage a persistent stapedial artery?
No. I don't use the laser. We have seen a persistent stapedial artery, and in this situation, we were lucky enough to manage to get the prosthesis aside of the Stapes artery into the vestibule, removing parts of the footplate manually. I mean,
but there are papers that people use small bipolars at a very low strength and to cauterize and all that. But frankly, I've never seen one. I've been lucky, I guess. But is there anybody here who has seen and want to give us some information? Amit?
I have seen 2 or 3, Manoj. I've seen 2 or 3, but I don't think you have to. As Munna said, you can actually go by the side of it. Very often it's not going to block the entire whole window. And the second thing is, somebody asked from the audience, that if you cauterize it, do you run the risk of producing a stroke or a No, not at all, not at all. A persistent septal artery goes and continues as a middle meningeal artery replacement, and it's a teeny weeny artery. I mean, it's really going to do nothing at all. The only importance you give it is because it's going in the surgical field. Otherwise, you wouldn't even look at it.
There have been some questions from the audience. One of them.
I've seen. Sorry, Manoj, you were asking. Yeah, I've seen one.
Yes.
Yeah, I've seen one, but again, like Mr. Muller said, there was enough space to create the fenestration and put the piston in.
Now, there has been a question by Dr. V.D. Pradeep Kumar, who exactly discussing what we discussed now. There's only a small gap between the facial nerve. You already know the answer, Dr. Pradeep, that what we do, if there is a gap, we will do it, use the special processes. And there was one by Dr. Ramakrishnan at Ambala Cantonment, Haryana. He said that, do you do per-operative assessment of hearing improvement on table? I don't do it because we do it under general anesthesia all the time. Professor Mullo also said everybody does it under GA these days. Do you all, Mohan, Shabir,
Yeah, it's
Neelam?
just on the table, we just, if you're doing under local anesthesia, just whisper to the patient close to the ear. A short whisper will roughly be around 35 to 40 dB. So it gives you a rough idea of patient's hearing, but not a formal audiometry.
You don't do any peroperative hearing assessment. There have been some.
First time I do audiometry is after 3 months after surgery.
Okay.
I do all my, or most, I think I've done under local anesthesia. So we do talk to the patient, check for, vertigo, tinnitus, anything like that. Also speak to them, like Professor Kameshwan said. Of course, that's not a very formal way of testing, but I guess it's reassuring our own selves.
Now, quickly, Nikhil Gokhale from Pune has asked about how do you do piston measurements? You saw in my video that I generally put the piston there and see if the ring is touching the incus on the top. That's what I do. I don't use a measuring rod. You saw Amit use a measuring rod. Neelam, what do you use?
I use the same as you, Manoj. I keep the piston and measure.
Professor Mullah, what do you do?
Well, we don't measure. We use 4.5 millimeter piston, and if this fits, that's okay. And if we have the idea that it's too short or too long, we open a new piston and take the adjusted length. So we measure, so to say, through the prosthesis we use, but in 95%, 4.5 millimeter fits always.
Same with me, Professor. I hardly ever have to change it. Munish Grover from Jaipur is asking whether, have you seen other ligament fixations and round window autosclerosis? Neelam actually showed a CT scan of a round window autosclerosis. Has anybody else seen any ligament fixations? I have seen one anterior malleolar ligament fixation my whole life of operating for nearly 27 years. So that's very rare. Has anybody else seen?
So I have seen, malleus fixation, like Joachim said. It's usually the ossification is the superior malleolar ligament, a condition which was described by Sir Victor Goodhill many years ago. So superior malleolar ossification fixation. Can also be involved in tympanosclerotic focus and in osteogenesis imperfecta. So that's a possibility, but it's very rare.
And I think what what Mohan said is right. If you have a tympanosclerotic focus somewhere on the eardrum, like laryngosclerosis, that kind of raises a red flag that you may have a ligament fixation. Never seen it with autosclerosis per se.
Now, see here, sometimes you notice ossicular anomaly. I think we'll have to bring up Monish's question here. So there was this particular patient that when this was abandoned, and we found a very small short incus to which we had to put in processes fitted at a slight angle. Can you see that? Yeah. So has anybody noticed, if you find a very short and thick incus, can you proceed or would you like to use a special processes?
Manoj.
Sorry.
Manoj. Yeah, you see, these are the cases in which I would definitely like to use the titanium processes.
Yes.
Because it can open up as much as I want and it can crimp as much as I want. The difficulty with polytef or this Teflon processes is it has a limit to which it can open properly and a limit to which it can close properly. So these cases I specifically ask for titanium processes.
Professor Mullah, your experience in these cases were anomalous.
Yeah, when we use this, we see this situation with variations at the incus, then we customize titanium prosthesis and bend it according to the shape, how it is needed to fit with the shorter process of the incus, and then it looks like a double L prosthesis and can be adjusted easily. So we start with a 5.5 millimeter prosthesis, and then we'll bend it according to the individual needs. This is also something what we do in revision Stapes surgery when we have erosion of the incus and the prosthesis has cut through the incus and there is a small remnant. Then we can fix this prosthesis in addition.
Remnant incus. So I just wanted to show you one video that I have seen once. So here there was this patient who had an anomalous looking stapes. lot of fibrous additions. This is a young boy with who actually went on to become an ENT surgeon. There's a lot of additions there, and then the foot plate was completely mobile after that. There's a completely mobile foot plate. And then we put in, after removing the Stapes superstructure, we put in processes between the mobile foot plate and the incus. And this is done about 8 years back. And till date, he's been having a AB closure in that region. So in these cases, is it good to put the processes between a mobile foot plate and the incus?
Yeah,
This is a nice solution.
yeah, you basically done an ossiculoplasty.
Ossiculoplasty.
Yeah.
Manoj, why do you want to remove the superstructure when the joint
I
is
did not
fine?
know what was underneath one.
Okay, right.
He had a, can you see the additions here?
Yeah.
Lot of additions. There was a complete addition. So I used a KTP laser at that time.
Right, okay.
Only after removing, I figured out that the whole foot plate was normal and mobile.
Yeah, because what you would have done is, if you once you've done the dissection of the fibrous tissue, you just check the round window reflex, and it was there. You could have just left it. But I understand your point. Sometimes you can't be sure unless.
He had a 55 dB loss, so I was not very sure. In
Fair
fact,
enough.
it completely.
But this highlights the point that autosclerosis is not always autosclerosis. You can have a lot of things. And Neelam made the point about the third window. I've seen this now. I'm seeing it even more recently. Severe subsectional syndrome is not all that uncommon in our patients.
Manoj, just a comment after what Mohan said. When we discussed the previous thing and we spoke about short and thick incus, I think it's also important here for those of us who don't have that much of experience, that at some stage you should also know when to abandon and say the patient may do well with an amplification device. Because at the end of the day, if you are going to do a lot of manipulation, sometimes the results may not be that good that the patient may get with a good hearing aid fitting.
Plus, in an anomalous year, it is unlikely that the hearing loss will progress, right? Unlike autosclerosis.
Yeah.
So you can actually leave him alone and him or her alone and give a hearing aid instead.
Yeah.
Is that what you're saying, Neelam?
Yeah. Yeah.
Yeah, Manoj.
Yeah.
Yeah. It's not a great idea not to do anything on the foot plate.
Okay.
The reason is, if you just put it onto the foot plate, then there is no medial, there is nothing holding the medial end of the processes.
Okay.
When you make a fenestra, it goes inside the fenestra, and that fenestra itself holds it in place. So your processes is fixed at both medial and lateral ends.
See, I completely agree that what I did at that time was really not good. But I thought, at that time,
I had three patients. I had three patients who had fracture of Stapes superstructure.
Okay.
And in all three, I have made a fenestra with a drill, micro drill.
Micro drill, okay.
Yeah, it's a mobile foot plate, but I still made a fenestra, and they are doing well. And my logic was this of making a fenestra.
Medial displacement of the foot plate is a dangerous thing.
Yeah, I mean, it will result into conductive loss again.
I actually, if I had the CO2 laser, then I might have done it. I was not very happy to do it with the KTP laser on mobile foot plate, and I did not have. I was not very sure whether using a drill would actually fracture and dislocate the foot plate.
No, it works very well. Manoj, it works very well.
Oh, great. I wish that you had shown one video of that here, but later. Now, does everybody here think that a very thick foot plate is dangerous to operate on? And what would you do? Starting with Professor Muller, very thick foot plate flush with the oval window niche.
Well, if the foot plate is very thick or comes from Australia and cannot be perforated with a perforator, I would take 1 millimeter diamond burr and thin it out, blue line the oval niche, and then open the foot plate with a perforator for the last 1/10 of a millimeter.
Okay. So is that what everybody does? That's what I do too?
Yeah. Saucerize the foot plate and then proceed.
Thank you, Finestra. I have a video.
I want to say one word to your nice picture, Manoj, with the prosthesis. I think this clearly shows the advantage, or one advantage for the Teflon prosthesis you use, because you can cut the stem in the desired length, and you put it
Right.
around the stapes. And this situation also helps you after trauma when you have a stapes crura fracture and a mobile foot plate. And if it does not work out, you can do in a second step still an opening of the foot plate and place
That's
a
a
different
huge
procedures.
advantage. You can cut it exactly on the direction that I agree with you, Professor.
Yeah.
Now,
Sorry to interrupt.
yeah.
Can we have some questions from the audience also? Because a lot
Yeah,
of questions
please.
are coming up.
Yeah,
I have put in the chat box.
I have gone through all the questions. What happened?
Oh, there's one that's come up just now.
Are results for congenital stapes fixation any different? Mohan?
Yeah, yes. If I had a congenital stapes fixation today, I would recommend a bone conduction device, rather than a stapedotomy, because it's a very high risk of going in for a cochlear loss post-operatively. Whatever, it's a very brittle cochlea. So these patients do much better with accept that they have a congenital loss, go in for a bone conduction implant.
Anybody else? Would you operate on a congenital stapes fixation? Shabir? Neelam?
Yeah, why not?
I also do operate, so I've not had a bad experience, but like I said,
My bottleneck is how is the incus? In a lot of cases, stapes will be fixed, but the incus can be so short, or it does not have a lenticular process or something. In that case, then I just stop. Otherwise, I would definitely make a fenestra.
okay.
I think imaging would make my decisions, because these less, Shabir said, there may be associated ossicular issues. These guys may also have associated inner ear issues. But by and large, if everything is okay, have done a couple and the results have been okay. I can't say that they are, worse than my others.
Neelam, can
No,
you...
they do very well.
do you think that you
Neelam,
can
they do very well.
Neelam, can you predict perilim gesture with imaging? With with somebody like Sanjay around, can you actually always predict it?
Yes.
We don't have Sanjay.
We don't have Sanjay. Okay.
Yeah.
So, see, I'm sorry. See, I have had gushers. I think I've had two, but they were long back, and I was so afraid that the recording was not very good. But one of them I lost hearing, one of them I got good hearing. So, but that is what people say world over. Professor Mullah, what do you think? Gushers, do you get good results, or are they kind of disappointing?
Well, they are very, very rare. And
to
my experience, those who I overlook and the ones I overlook from my teachers, the results are poor.
Poor, I know. I think they're very poor too. So I think we'll have to have somebody like Sanjay to predict those things. Have you had a gusher, Amit?
No, not as yet, fortunately.
Neelam?
I've had one.
What
Long
happened?
back.
Hearing?
I've had one long back. I think it must have been at least about 20 years back. It was a nightmare. I had to abandon it.
Abandonment.
Yeah.
No, Manoj, the gushers are not necessarily, full gusher where, the CSF is coming out of the canal.
That's what we meant by gusher, full gusher.
Yeah. So those are extremely rare, but a little excessive flow of perilymph is, I would not call it as a gusher, but I do not know what to call it also as.
Boozer.
They do well. Boozers, yeah. They do well,
Yeah,
yes.
Now, one more thing about floating foot plate. So if you have seen a foot plate that is, floating, you try to do a fenestra, part of it is gone move away. What will you do? Can you do a total stapedectomy? Do you put a graft and then do it later, or try to remove it with a pick or laser?
Manoj, I think I showed a video of this.
You showed it.
Two options you can do. Of course, this is a perfect situation for laser. Really the perfect situation, because you don't have to disturb the foot plate at all. It's floating, so just make a rosette in the middle and put a fenestra, put a piston and come out, and that's the perfect situation. But if you want to, then what I did is you just press on the anterior part of the foot plate, and the posterior part of the foot plate will tilt up, and you have a small gap between the oval window and the posterior part of the foot plate. Put a right angle pick through that, and just move the whole thing forwards, and the whole foot plate will just flip over. That's a total stapedectomy, of course, but you can put a piston and then seal off nicely with soft tissue. My choice is fat, but you can also use fascia. So it doesn't mean that the patient is going to have a cochlear loss. You can preserve hearing and get good results. So, and these are the two options that you have. I've also seen a surgeon drill the upper lip of the promontory to create space below the floating foot plate and put a
Take
hook
out
through it
the
and
floating.
pick it up. Yeah, that's the other technique I've seen. I've not done it myself, but I've seen it.
But Amit, we have all been taught that if there is a floater, don't meddle with it because you might cause more trauma. What do you think?
Yeah, I agree. If it's, we have access to laser, like Professor Mohan said. I would use a laser. Sometimes I would take a call on the table if I feel that I can, just pick it up like he's shown. I'll do it, but I won't really be diving into the thing to take it out. I would, if
There's
something
a
like that, then I would.
question for Professor Muller. People are asking, is there any special precaution for people with osteogenesis imperfecta? You did mention about Van der Waals syndrome in your talk, Professor.
Yeah. Well, it depends on the type of Van der Waals syndrome, and you should consider the proportions of the middle ear and the proportions of the eardrum if it's a severe appearance of the disease. If it's the lighter one, then the only precaution is that you should know that the bone, once you perforate the foot plate, is a little bit more smeary, and you have more danger that the particles dive down into the vestibule. So
your long-term results in osteogenesis imperfecta, Professor?
Pardon?
Your long-term results in osteogenesis imperfecta, how are they?
They are comparable like a stapedectomy. The crimping should not be too tight because of friction between the prosthesis and the long process of the incus. But the typical finding is column stapes after stapes fracture, and that if that is removed, it can be replaced with a stapes piston easily.
Anybody else got anything to say on
Manoj?
that?
Yeah, I mean, one of the additional problem with osteogenesis imperfecta is the malleus and incus can also fracture very easily.
Okay.
So, I mean, I have had a case in which I fractured malleus just when I was trying to mobilize to see whether it is moving or not.
Okay.
And I had another case in which I have fractured an incus long process again during this process before even I could go on to the stapes. So on both the cases, I had to just abandon it. I mean, I thought there was no point in doing it further.
Now, there's one more question, but before that, we will talk about this. See, this is what Professor had mentioned. I think here there was a patient, this is my patient, who had a very badly eroded incus. So what we did, instead of actually taking it out, putting a malleus vestibula, I agree with him that that gives very, very, very dicey results, not very predictable. So we actually put a clip piston after making a fenestra, as a revision case, put a graft over it and put a soft clip piston over the remnant of the incus where it was not eroded. I think Professor Muller alluded to that in his talk. Didn't you, Professor? Didn't you? So that's supposed to result following a Kurz piston on the eroded incus. Professor Muller, you did mention about this, right?
Yeah, I mentioned about incus erosions after having initially used a clip piston. And this led to an erosion of 50% of the long process of the incus. So
like this.
I think you're right. In this situation, the titanium prosthesis would be the solution. And if the soft clip, which is a little bit less tension applying on the incus, fits on the remnant of the incus, then you're doing fine. But it will not avoid, to my opinion, erosion of the remnant of the incus, because the clip closes always to the same diameter, and then it applies
The
forces
original
to
one here was a Teflon piston. So I do not know, but we have been following it up. This is now 2013. And we have been following the patient up for now 10 years. So far, so good. But like you said,
Yeah.
we always keeping our fingers crossed.
Yeah, but this is a fantastic result.
This is mallear vestibular processes, which we use. It's a very old thing. You did mention about this. I have done a few, but like you said, I don't always get good results. Here I used a measuring rod. I denuded the. Let us stop playing it. So here we opened up the ear, and we after inspecting the ossicular chain, we found that here the chain was actually completely eroded near the body of the incus. I couldn't get any, say that was too much erosion. And you can see the piston pristine condition after 20 years lying inside the middle ear. So the malleus handle was bare completely, and that's a cut end of the chorda that you see there. And then we took out the incus, and we had to put a process. You can see the fenestra there still. You can, it's still in good position. That is there, and that we opened up slightly. Just a membrane is covering over that, and put in the piston between the malleus with the bucket with the ball and socket joint. This one, the malleus vestibular by Kurz. You have to put it first onto the malleus and then put it onto the vestibule. In this particular case, I did get good results, but there are a few that I didn't get good results at all. So like you said, it's a bit of a touch and go, Professor. I think you alluded to this also in your talk. Anybody else, Amit or Neelam or Shabir or Mon, used the malleus vestibular processes by Kurz?
Used it twice, and the results haven't been all that great.
Okay.
I've used a different one long ago, not this one, a different longer prosthesis, but I didn't get great results with the malleus vestibular.
Same thing, Manoj. Not very happy. No, not very happy. I have abandoned doing it.
Okay.
I think what Neelam said is right. You get good results immediately, but then gradually with time it goes down.
Time it's gone.
Here again, one more case where we had a shortened incus, and like what was mentioned earlier, a Kurz piston was put on the remnant incus. I always worry whether this will stay there. Has anybody done this Kurz soft clip on a necro incus? I think Professor Muller and I have mentioned, but has anybody done this?
Manoj, it'll always erode up sometime. Yeah.
The bad news for the patient, but we'll follow it up. Now, this is one of my own patient that I had done and initially got good results, but later, and this was maybe I think about 8 years after surgery, patient continued to have a conductive hearing loss. And then I found that there was a lot of, see, that's a piston there, and strangely the incus is not eroded. This is my own case, and the incus was mobile. But what we found that was that the crura was still there. It was, I had actually done a reverse, but I think the part of the crura was still there, which we had to cut off from the anterior crus. Was it because the anterior crus was too thick and I didn't fracture it properly? That must have been the reason, because the fenestra is still there. The incus is still there, good. But only the anterior crura was left behind. So all I had to do was take out the anterior crura and put in the same processes, and the hearing improved. So what do you people do to ensure that the anterior crus is also not left behind like that? This was my pre-drill days when I used to use a handheld perforator.
Manoj, if the anterior crus is left behind, as long as it's not in connection with the incus, it shouldn't matter. Because it shouldn't matter because even if you have a little bit of an anterior crus there, as long as it's not in connection with the joint. I mean, if the joint is not intact, it doesn't really matter.
Why did this particular patient was having a fixity? This particular patient, has anybody seen that? I've never seen this after and before.
Manoj,
before the anterior crus, it was all right. Shabir?
Yeah, Manoj, when you fracture the posterior crus after drilling it, that is how you have weakened the posterior crus and then now you are fracturing it. If you see your head coming out with the posterior crus, it really, you have disconnected it from the anterior crus. The remaining part of the anterior crus, as Mohan said, even if it is there, it doesn't really matter. But if the head is still there, then of course it matters a lot.
That this was my times long back when I was doing with the perforator. I think while fracturing, I may not have removed the whole crus. I think that's the only explanation that I have.
Yeah, but the head, if the head has come out, it really does not matter.
Better. So it is possible that I fractured and removed only part
Posterior
of the
crus.
posterior alone and left the head behind. So that is something that, Amit, do you think with the laser it won't happen to us?
Yeah, I think if you have the laser, you can fulgurate the base of the anterior crus. But like already mentioned, if the head is not there, then it should matter.
Yeah,
there's no contact.
These are difficult. So this is one case that I want to share with you. This person had some surgery to correct hearing loss and was okay for a short period and then worsened. And then we put a standard transcranial incision and found that the incus was kept on the stapes. When ossicleplasty was done, the hearing had not improved, and the stapes superstructure, you can see that there was incus interposition there. Stapes was one fixed. So I had to take out the incus. This is done 10 years earlier. It was found that the stapes was entirely fixed. The malleus was mobile. So I cut off. So it was completely fixed. Initially, I thought it was tympanosclerosis, but it was not. So I had to drill away the crus. I put in a vein graft and very small piece of vein, and then made a fenestra, sealed it with the vein graft, and put a malleovestibular processes. That's the same thing, same as what I did before. Now here, everything seemed all right, and the patient went home. It looked good to me. It was nice and fitting. It was fitted on the incus, on the malleus handle, right into the vestibule. I put some fat in addition to the vein graft. Everything looked fine to me. And closed the flap. But on the third day, next day, patients start bleeding from the ear. And there was severe vertigo and vomiting. When I go there, I find that the whole ear is filled up with clots and pushing the drum medially. So we went inside and opened up and found that everything else was in place, except that the drum had pushed the vestibule medially. This is what Neelam meant by a medial displacement piston. If you see it radiologically, you'll have to immediately interfere. You can see the whole blood clots in the middle ear, everything. So we sucked everything out, found that the processes were still in position, not a bleeding, and took the processes out because I wanted to be sure. Reapplied it and tested the round window reflex. You can see it there. You can see the round window reflex. And then close the flap with a little bit of tracheal cartilage for drum support because it was very thin because it was pushed inside.
Why the bleeding?
I have no clue. And this was a patient, see, this 2011 it was operated, 57 dB left ear. And you can see the postoperative airborne gap closure, not so much in the high frequencies, after the second surgery. This is what it was. I really do not understand. Has anybody else had a experience like that, have bleeding and have severe postoperative vertigo?
The only patients who bleed like this, Manoj, are the ones who are on antiplatelet drugs for various things. So one thing you got to check out. But I mean, as Neelam said, there's no reason why, even if you have a displaced piston, that there should be bleeding. Interestingly, I just wanted to touch you on a topic that, that for many years, House Ear Institute used to put a drop of blood into the vestibule when putting a piston because their logic.
Okay.
The fibrin would form a nice lining for the piston. So they deliberately used to put a drop of blood into the vestibule and then put the piston. Because I think they've stopped now. But basically, bleeding per se, cannot happen from just a displaced piston. There must have been some other.
I just
Something
must
else,
have
yeah.
got displaced immediately. That's all.
Yeah, but I mean, why the bleeding? If it displaces medially, patient will get vertigo. Manoj, Professor Muller is leaving to see the child. Yeah.
Oh, you have to go. So thank you so much, Professor. We'll meet you in Sujicon. So
Yeah, I apologize. I have to catch a
it's
train.
okay. We are taking too much of your time, Professor. Thank you so much.
Thank you so much. Okay, catch you.
Thank you very much.
Bye-bye.
That was
Bye.
great.
Thanks
Bye
to
bye.
all the audience and
Yes,
us. We have taken too much of your time. Sorry.
No, it was very enjoyable. Thank you very much. Seeing you soon in India.
Thank you.
Bye.
Thank you, sir.
Bye.
Now, just two more questions. What will you do in far advanced autosclerosis? Starting with Amit.
If I would offer them the option of Stapes surgery with a hearing aid if I think that we can improve their hearing threshold. Otherwise, discuss the cochlear implant.
For information of the audience, it is more than 85 dB hearing loss. Neelam?
I think my decision would depend on a combination of imaging and audiology. Imaging to tell me the extent, audiology to tell me specifically what is the element of an airborne gap and what is the speech discrimination score. If I have something which is less than a 30% on a speech discrimination score, I'm looking at a CI as a primary option. If I have a good airborne gap with a decent or a 50% speech discrimination score, then it would be a stepidotomy. So it'll be a combination of both these that will help make the decision.
Imagine that you find 2C, Simmons-Fanning staging, and you still have a good airborne gap. Would you go do a stepidotomy or a cochlear implant?
A stepidotomy first.
Mohan?
Yes, I agree with both of them, both Amit and Neelam. Only additional point I would like to make is I rely a lot on Weber. If Weber goes to that year, that's take up a stepidotomy.
Shabir, have you done a cochlear implants in otosclerotics?
I mean, primarily I would prefer to do a stepidotomy if there is a good speech discrimination.
Okay.
Because there is no point in improving the hearing without discrimination.
Okay. There's a question from the audience which about this. Okay. There is a profound hearing loss in 1 year. Another year, there is a good airborne gap and a pure conductive hearing loss. Would you offer implant on the dead ear or surgery in the other ear? How do you counsel the patient, or you give hearing aid in the better ear? Mohan.
Yeah, I have now, in fact, a whole series of these patients. Patients who have got a conductive loss on one side, who had a stepidotomy which has failed, or progressed to profound loss in the other ear. So my advice for them is to use hearing aid in the good ear and then go for a cochlear implant in the ear with the profound deafness. And after having had a cochlear implant and having good hearing on the ear, then they have a choice whether they want to continue with the hearing aid or whether they want to have an option of stepidotomy in the good ear. So, I stage it. First is to give a hearing aid in the good ear and then go for a counsel for a cochlear implant with the profound ear. And then, of course, the patient.
What would you do? You get a patient, dead ear, one side operated, and you get a good AB gap and in the other ear. Would you do a stepidotomy in the only hearing ear?
Who are you asking this to?
Shabir.
Manoj, this is interesting. The way I would go around is I would definitely want to know who is the first surgeon.
Okay.
If you are the first surgeon, then I'll keep my hands off from the other ear. What I mean is, if the previous surgeon is an experienced surgeon and despite that he has got a complication, the same thing may be reflecting on the other side and I would get into a similar sort of situation.
Neelam?
But if I have a surgeon who is not very experienced, then of course I would go around with the Stapes.
Okay. Neelam?
Imaging to know why this happened first. Secondly, I would agree with what Mohan did, which is I would give a hearing aid in the only hearing aid ear counsel the patient about a CI in the other ear to give him the advantages of bilateral, and then take it from there.
Amit, agree with that, or would you do a
Yeah,
staphylotomy?
no, I would not. Same as what Neelam and Dr. Mohan have said.
I guess then I'm the only person who's actually doing staphylotomy in the only hearing ear. After counseling, yes, but we tell them that if it fails, they need to do a cochlear implant. And I guess that, I think both these answers are actually right. But
My only discussion about that, Manoj, is, every patient initially tells you, yes, I'm all for it, even though you and I tell them all about the risks. But, if something was to go wrong, you never know when they're going to just say, why did you do it?
And also, Manoj, it's not defensible in a court of law.
Okay.
If things go wrong. So, I think that's probably the main consideration today.
There are a lot of papers, Mohan, on staphylotomy on only hearing ear. No?
Yeah, there are. But, the alternatives are clear, that you want to give a hearing aid in the ear and you want to give a
It is very rare to have somebody like that, but we have, after counseling, we have offered them both and they have chosen, but like Neelam said, so far it's gone well, but if it doesn't go well, I'll be in real trouble.
But it's 100% loss for that patient.
Yes.
It may be
very difficult to justify it.
Amit, and Neelam and Mohan, my reasoning is, I tell them that this may also go wrong. Chances are low, but it may go wrong. And if it goes wrong, you have an option of cochlear implant.
My logic here is all that you and I say, and this is something which is documented. The patient hears what he or she wants to hear. And when things go wrong, then, unfortunately, from a medical legal aspect, we have nothing in literature that will support us, and we will be in trouble. So, that's the point. It's what they want to hear. At that point, they're listening to you and they're saying, okay, I'm going to take that 98% risk of everything being a success, 2% chance of things going wrong. But if they are in that 2%, believe me, they may be in trouble.
They behave differently.
This is just one video about this patient who had an abandoned surgery with a floater. What the surgeon actually did was fit in a fascia and then came out, which was sensible because it didn't do anything at that point of time. So here we had to, this is in relation, I just put this question here because somebody asked about that. There was a big fracture on the foot plate with a perilymph leak. You can see that. Can you see the fracture anteriorly?
Yeah.
And then we tried to make a fenestra and with a laser, but eventually ended up removing the whole foot plate because it could not be removed like that. So did a total stapedectomy and put in a big piece of perichondrium as a graft and put in prosthesis. So this is where a stapedectomy, Mohan, I think in a case of a big fracture, stapedectomy would be the only thing to do, right?
Definitely, yes. And the word, just to preoperative assessment, if you're suspecting in a post-traumatic case, conductive loss, suspecting possibility of fracture crura, remember it's the only situation where you will have a conductive hearing loss with the presence of a septal reflex.
Okay.
It's the only situation.
So here also, see, even with the stapedectomy, there is a good result, but still, we would like to avoid this in the first place, like what was said earlier, by using good quality instruments. So I think that comes to the end of the questions that I have placed. Somebody has asked that, is it possible to have a normally mobile malleus with a restricted mobility of the incus? There is
a dislocation of the malleus anchor joint.
So in that case, malleus is mobile, but incus is not mobile. What would you do?
It's not in connection with the malleus.
So one more question, back to the same thing. SNHL in 1 year with autosclerosis in the other, can we operate?
I think we discussed
it. Depends upon how much SNHL, right? If it is not bad, we can still operate, isn't it?
Yeah. If it's aidable, then
dB SNHL in 1 year and 65 dB conductive in the other, we can safely operate because that year is still aidable. There is somebody asking, tell us about pre and post-operative medical treatment for autosclerosis. Anybody does give autoflow?
There's no medical treatment for autosclerosis, either pre-op or post-op.
There is this biphosphonase that was described in a paper.
Ah.
Amit, have you heard that?
Nothing.
Yeah, I've heard about it. I've read those papers, and there was a description in one of my previous talks. I've alluded to that. But there are downsides of bisphosphonates. So really not something to be chasing right now.
And it's
And I
not
think
it's
all
not
those papers also refer to the activity of the disease.
Yeah,
I mean, from what I remember,
Yeah,
that's right.
you know, I think I looked at a couple of them. It really refers to it. You can only use it in the autospongiotic phase,
Correct.
which is
You know, there's a very good paper years ago from Vellore, CNC Vellore. Professor Desmond was there at the time. You know, one of the few people doing staphylotomies at the time, and he pointed out that some of the districts in Andhra and Tamil Nadu, which had endemic fluorosis, were also districts where the autosclerosis was prevalent. So, in fact, you know, if fluoride was going to prevent autosclerosis, it shouldn't happen. Yeah, disease with fluorosis should not have autosclerosis, but unfortunately, they were also the disease where they had very high prevalence of autosclerosis. So, you know, the whole thing is humbug.
There is a question that has come up now, role of vein graft. We have gone 45 minutes beyond time. Vijay, I'm sorry. So, role of vein graft. Shabir, do you use a vein graft?
Used to. Now I don't.
I don't use. I used to use a loose lot either. Mohan, vein graft?
No, fat.
Neelam? Amit?
No, I used to stop doing it, but even the studies, the vein graft will not affect your acoustic properties. It's only from the point of view of, you know, vertigo and pale lymph leak. So maybe, as Robert will tell you, maybe in aviators and people like that, you know, you may be tempted to do that, but that's it has nothing to do with it.
I think it's with the evolution. We've all started doing stepidotomies. I think this was more in the era when there was more of total stapedectomies.
Stapedectomy, then when you use vein graft or like fish use perichondrium, and you know, so now things are different. I don't even use fat if I have stepidotomy.
I don't use normal. Fat either.
I don't use any. I mean, I just leave it and like said, blood will seal that place.
However, Neelam, this was described for stepidotomy, not stapedectomy.
Yeah.
Whatever, but I think none of us now use vein grafts. So.
Vijay, are the people still there? They all left. Or just the 5 of us are here?
We are enough for each other, Manu.
Good enough. We had a good time. I think we had a good discussion among ourselves. So, thank you all. It's been a great evening.
Thank you.
A lot of information that came through. Neelam, fantastic talk on radiology. I really loved it. A lot of points that I every time I talk to you, I learn a lot. Mohan, great points on the use of different materials and especially serially dilating. Now I should get those 7 speculum set, I think. I think I'm going on with this 4 speculum set, which I have decided to junk it after listening to you.
Make sure you get one for me also.
Yeah, get one for you. Amit, those comparative studies on lasers are fantastic. I think you're good.
Very nice.
I think after getting the CO2, I'm really kind of hooked onto it. But like you said, it's not essential. It just adds onto the bill, I think, more than anything else. Shabir,
Manoj, thank you very much for before you say anything, thank you very much for not insisting on me presenting anything. And
Neelam took over. You thanked her. You have to
thank
thank
you so
Neelam.
much.
Neelam took over. She took over. Told Neelam to take over your talk. When I have friends, why do I have to worry?
So thank you very much. Lovely time.
Thanks so much. Thank you to IAOHNS for encouraging us to keep.
Yeah.
I can see Gautam there.
On behalf of IAOHNS, I have the pleasure of thanking you all for a very fruitful, very interesting panel and discussions on difficult scenarios in Stapes surgery. I think everybody must have benefited. I personally have learned a lot, and you have delved into the basics, and you have also gone into the complicated situations. I think it will be very useful for everybody, and it will be available on the net for others to see and again come back and see whenever they wish to for additional information. Professor Muller has left, but wish to be on record to thank you for his time. And Dr. Manoj is always, he can bring out the best of everybody. And we have all the masters here, Dr. Mohan sir, Dr. Neelam Ved, Dr. Shabir and Dr. Amit Kishore, my friend, and you have all been, we have been very enlightened by your discussions, and then also thanked GSK for continuing this activity with us. Thank you very much.
Thank you.
Have a great day.
Bye.
Thank you.
Good night, guys.
Bye-bye. Good night.
Thank
Thank you.
you. Bye-bye. Vijay, thank you so much. So bye and have a good evening. Thank you.
Thank you.